I think we start now moving to the thematic groups, and let's listen to the disaster risk reduction and climate change MHPSS group from Brandon and Matthew.
Thanks, everyone.
Good morning, everyone. Nice to see you again today. So I'm Brandon. I'm from WHO, co-chairing this thematic group on MHPSS, disaster risk reduction, and climate change. And I'm joined by Julian, who is not Matthew, but he is representing in one of his 16 different roles. He's representing CBM because my co-chair, Matthew Hanning from CBM, could not join today. CBM Global. I will also make this correction. So thank you so much for joining to give this presentation, Julian. So let's see, we start with what has the group done in the past year? What have we achieved? The first thing we wanted to talk about as a group was the development of what we're calling the MHPSS Ready package. So this is a 3-day training package that is all focused on operationalizing what it means to have MHPSS a part of disaster risk management. So it's very focused on preparedness, on risk reduction, and in, I guess, a different area of focus than we maybe typically work, but where we see more and more things happening. And then the purpose of this training package is to work through a process to identify where MHPSS can actually be integrated in a disaster risk management strategy within national or agency-based disaster risk management teams and structures. So what's happened so far is the package has been pilot tested in 3 countries, and then in the last year revised quite a bit and strengthened based on those pilot tests, and also used by WHO, taken and adapted a bit and used by WHO components of it in 3 global capacity building workshops as well. And on the screen here is a picture from one of the pilot tests in Sri Lanka by Ananda and MHPSS.net team. So what's next is, this has been in the works for a long time, so we plan to test it one more time now that it's been revised and strengthened a bit this December in Bangladesh, between WHO Bangladesh and UNHCR Bangladesh, at the national level, but also with a focus on Cox's Bazar. And then to design the final package and put it out for further field testing as a field test version by different agencies within the thematic group, and also hopefully other agencies who are not in the thematic group. Second thing, we've been working on developing assessment tools for MHPSS preparedness. And the idea of this is to create some things that can be used to integrate MHPSS in disaster risk assessment. This is separate from the multi-sectoral MHPSS assessment toolkit, but we hope it complements it. And the idea is to create something that's useful for assessing risks to mental health and well-being, assessing capacities in a preparedness phase or more within DRR context, and then also have a tool focused on communities' perceptions of risks, of potential hazards, and what local resources exist to build upon through disaster risk management. So this tool so far has been developed, and then it was pilot tested in Namibia at a workshop with Africa CDC with 10 Southern African countries. The workshop focused on Mpox, so it was an adaptation of the tool focused on Mpox. We'll also pilot test it in Bangladesh later this year and hopefully in one other setting, and then also put it out as part of this field test package with the MHPSS Ready package. So the group saw this also as another big achievement this year. Then a third achievement, I think we've focused a lot in this group on raising awareness of the integration of MHPSS within disaster risk reduction and climate change adaptation, but trying to get more into those spaces and more with those actors. And we struggled with that for a long time. But in the past year, I think we've done a lot more on the topic. So, for example, we had an event at COP28 last December where we released this video that is called the Mira video. It's a cartoon storytelling video that has the story of this young girl who's affected by a climate-related hazard, a flood that destroys her village, impairs a lot of people in her family. And the story is her having a dream of what things would be like if she had this time machine to go back in time, and things were different across the phases of prevention, preparedness, response, and recovery. and included MHPSS in different ways. So this tool has been super useful for us to engage with the DRR community and the climate change community, because I think it's very accessible in that it's storytelling and it does away with jargon and acronyms and just tells a story. So in that event we used it, but we've also used it in many other settings, from national workshops to regional workshops. And then I used it in Indonesia recently with climate change focal points from 11 different countries, and it really seems to work. So I think this is another big achievement of the group. And then also it's been used and mentioned, some of our work has been used and mentioned in other settings like this resolution from the World Health Assembly this year as an explicit mention of the IASC MHPSS DRR technical note. So we saw that as a big achievement as well. What are we doing next? For that, I'll hand to Julian/Matthew.
Yeah. So just to emphasize really how we've tried really hard in this group not to just be talking to ourselves. It's very easy to do that, especially when you have such wonderful colleagues, of course, but it's much more important that what we have to communicate is understood in completely different spaces. So in this particular case, as Brandon said, we initially really struggled to engage with the disaster risk reduction community because it's an enormous community. They have their own conferences, their own meetings, their own spaces, but we've tried really hard to engage with them. So that's going to be a big theme going forward, really. I think as we have those relationships, we'll continue to build them. But concretely, we're going to be taking forward the field testing of the MHPSS Ready tool. I know it's confusing because we had another Ready tool talked about yesterday. But taking that further, engaging more with these other communities to make sure they understand it. Okay. This community has, as I said, its own spaces, and we were at COP28, but there's a plan also to now be in COP30 in Brazil. Part of that is engaging with other people who are doing mental health. I know that at COPs there are increasingly different people also doing mental health, so linking up with those people as well, including people who are doing more research. But the kind of big event for the DRR community is this global platform for DRR, so we're planning to present our work there as well.
Yeah.
And then finally, for me, taking these tools further. So we've got some, as often happens, with the core work is done, and then there are specific communities and groups that we recognize the need to be a bit more focused on their particular needs. So some ideas about developing more work around child-focused, DRM guidance and resources, different ways of strengthening this idea of social cohesion, resilience. I think resilience is a term that's used a lot, and people often turn to the psychosocial people. And I think we need to work that out a bit, what we mean and how we can actively build it. And then, as often is the case, I think we've worked a lot in conceptualizing this intersection, but how do we make that more real to people who are trying to make it work in their communities?
Thanks, Julian. Yeah, so then we asked the group what are our main challenges, and I think something is we just need to keep working on this topic of where we can find entry points in the DRR and climate change adaptation fields. Something the reference group co-chairs have already done is helping us with that and sharing when those opportunities come up, but I think that's the main challenge we face. We have a very active set of core members of the group who've been there all along and continue to be, so the biggest challenge is just keep finding opportunities for this. And I think we can also link with this, with the advocacy group better, or maybe we haven't done it at all, so maybe we could do that better to kind of identify some of these ways that we can move forward, right? Yeah. So then all of this comes to say we suggest we would continue the group because there are a number of things we think the group could still do in the next year.
Maybe just a closing thought. It's something that you will have heard many times in this community, that we should never waste a good disaster. You know, MHPSS has often grown during points of crisis where people recognize the kind of emotional needs of their communities. There's nothing bigger than climate change in terms of shaping our future, and we really need, as a community, to be on top of how we're going to contribute our part to addressing that crisis.
Thank you. Thanks. I think that's it for us, unless Sarah has a question. Okay. Maybe, I don't know if there's time for questions. I will defer to...
Let's pick a couple of questions. I have a reflection as well I want to share. But thank you so much for the co-chair agencies.
Thank you so much. That's a great presentation. It's not so much as a question as just an invitation that maybe the focus on child-focused resources for disaster risk management could be a collaboration also between the Child and Family Group and yourselves. I think that would be great.
Absolutely. Thank you, Marie.
Thank you. Thanks, Brandon and Julian. A quick question on the disaster. This is not my area. The preparedness assessment tool.
Yes.
Is that linked at all to the assessment tool that's coming up this afternoon?
Yeah, it's a good question. So we've talked with the MSP team on how we can make them speak to each other, and we're working on that still. So hopefully the answer is yes. I don't want to speak for Inca as well or from UNICEF side, but we're trying to make them talk together. So this one is very much focused on preparedness, and it refers to that tool as anytime you're talking about response assessment, you should be using that tool. And this is kind of the idea of maybe a step before if you're working in a preparedness setting or more in development. And that's the focus. We're trying to really emphasize this is not for that, and we're not overlapping with that toolkit. But we're still working on making sure that that's actually how it plays out. Yeah. So the answer is that's the goal. I hope so it's like that, but we're going to try to make sure it's like that. They're linked, yes. And they refer a lot, this preparedness assessment refers a lot to the MSP when talking about any of the activities that you're assessing, if they're there or not. So there's linkages, but we want to make sure it's good. That's why, yeah, that's a big focus of our pilot testing.
Thank you, Brandon. I propose very briefly, we take the question from Isabel and the question from Guillaume, very briefly with brief responses. Colleagues, please.
Sure.
Yes, thank you. My intervention will be very, very short. Just thank you for the good presentation. Just a question, are you interacting with the UNDRR office? Because I'm asking this because there's a colleague there who is very active on disability inclusion, and I suppose that there might be also openings, if not already the case. So I can put you in touch if necessary.
That would be amazing if you could. We have some connections with UNDRR, some at certain regional offices, and then we've had connections at headquarters, but there's been turnovers, so there's been lapses in that. We're trying all the time to stay more connected. So I'd love to be connected with your call. Yes, please do.
Just before I hand the microphone to Guillaume, there is a new inclusive DRR training which has just been released, and it's kind of on social media. So I'll try to find a way of sharing that with this group here.
Marion, I see you raised your hand, and I cannot resist because I guess what your question is. So I think we very quickly get the question from ACF, then HelpAge, please, very quickly.
Yeah, thank you. No, it's not a question, it's just an information. I have to share that we have worked with different colleagues coming from HI and PUI on a new tool, multi-sectorial environmental risk analysis matrix for shelter, WASH, nutrition and health, and MHPSS. And if any organization work on how assessing the risk, the environmental risk of MHPSS activities, you can join us. So the tool is finalized. It's a very, very short tool because, as you know, MHPSS staff, we have a lot of standards to integrate, and environmental standards could be very huge. And the idea was to, I don't know if you know NEET Plus, but NEET Plus is a huge tool for shelter, WASH, and health. And we decided to just decrease the number of mitigation measures for MHPSS. So it's available, it's online in French, in Spanish, and in English. So if we discuss with Brandon, maybe it will be integrated in the next plan of this group. But if you want to have more information, we can discuss about that with Simona too.
Thank you, Guillaume.
Let's get the intervention from HelpAge, please.
Just a comment, not a question, but HelpAge has an age-inclusive disaster risk reduction toolkit from 2019. Other colleagues developed, so I'm happy to share that.
Please do. I'm not familiar with that, so please do. Thank you. Thank you, Marion. Tell me you had a reflection.
Sorry. Ananda, if it's less than 15 seconds or 16, I think we can.
Just to say, amazing work for this group.
Yeah.
2015, when we raised DRR, the Sendai framework had been passed. No one in the reference group knew what DRR meant.
Yeah.
And we have come a long way, and I think this next year is going to be critical for getting some of this really important stuff out. So well done.
Thank you for all your work in the group,
Yeah,
Melinda.
really great work, colleagues. Yeah, indeed, this is a great example for a good group. I agree. Couple of important points. The point you raised, because they are architecture-related issues and governance-related issues. The point you raised, Julian, ready. There is another ready. Very good point. But MSP, we got another MISP, which is for reproductive health. IC guidelines, we got other IC guidelines. IC guideline on disability, IC guideline on GBV, and so many others. But we add the MHPSS component. It's the IC MHPSS guidelines. It's the IC MHPSS MSP to differentiate it from the reproductive health one. And we can go on with several other examples. So it's, I think, the MHPSS identifier and link. And I think actually the ready package, the name was coined before the other ready package and link it to the acronym. It would be very difficult to change because this one also got branded and start to be used. And if we decide, but I don't think we should change the names of many things we use, especially if we label it as MHPSS ready or MHPSS preparedness ready package, which create a distinction in branding, unless the group decide otherwise. The co-chairs, we thank them, they mentioned co-chairs are available to continue chairing, and that's the correct wording. It's good to announce that. However, the co-chairing of the thematic group, I want to kindly remind you, based on previous years, because we also have many observers, that's decided after this meeting, before the end of the year, for the thematic group, each member agencies and observers as well nominate whether they would like to be members of the group or not. And then for member agencies of the reference group, they nominate themselves if they wish to be a co-chair for that specific thematic group. While this offer comes, this is not validating this offer during this meeting, because the validation comes in the weeks to come before the end of the year, where we know who will be the co-chairs of various thematic groups based on the member agencies nominating themselves. I think we move to the next thematic group led by Terry for moderation.
Indeed, I think the next thematic group that is going to present is on mapping and assessment, and that's Marcio and Inka, whenever you're ready.
Yes. Yeah, you do? There are others that are short, but you can. Okay. Great. So I think you know us both. We have been together, WHO and MHPSS.net have been co-leading this group now for a couple years. And when we were here last year, we were actually presenting to you the process of what we did to learn from the past 10 years of using other assessment toolkits like the WHO UNHCR 2012 version, for example, to see what can be improved and how can we make this toolkit better, more multi-sectoral and so on, working across different clusters, AoRs, and working groups. So since then, we have taken all this feedback and have actually released in July of this year the multi-sectoral assessment toolkit field test version, which is now online, also on the MSP website. You see a tab there. We also have done a 1-hour webinar in English and French on the toolkit that can also be downloaded and watched from the website as well. And we have translated the toolkit into French, Spanish, and Ukrainian. And we're also field testing the toolkit at the moment in 13 countries. The slide. Okay. Sorry. Yes.
So, imagine a place where you can find all the needs assessment that has taken place so far, all the desk reviews that we have done so far, and that was all the mappings that has been done so far. We found a place now. So there was a lot of background work to develop the MSP the multi-sector needs assessment toolkit, and all this collection of work. There was some of this that we had to harass some people to share, but we managed to get all of them, and they are now here. And this is live. They were supposed to have a QR code here, but yeah, this is not the version then that Ananda is going to share in the group then. But yeah, that's where you can find, and that has been now for almost 100 resources, and it's live as of today. But keep sharing, keep sending, and to make this as not a past, than just a library, but a live document.
Yes. I use.
Next one, yeah.
Yeah, I just want to say we're so grateful to MHPSS.net for this repository. I remember going to the field and just emailing people left and right. Didn't you do an assessment in this country? Can you send it to me? Asking around and digging around, and it's just amazing. You can just go to the website, click on the country, and you find all the assessments that have been done there that we know of. We even have historical assessment from the 90s, like done by Nancy, that we scanned in. So we're very, very happy about this and very grateful to MHPSS.net. So please use it. Let us know what you think. We can still take feedback on it as well as we go on. Where are we today? So I mentioned field testing. As you know, through the IASC mail out, there was an announcement earlier this year that we had small grants available for field testing, and we received some applications for that. So this resulted in these countries and organizations who are now field testing it with the small grants. Burkina Faso, World Vision, Chad, World Vision as part of a consortium, PAHO in Haiti, Kenya also World Vision. You see a theme there. World Vision was very, very active there in submitting applications. Tajikistan, MHPSS Resource Group, and Uganda, HopeLink Action Foundation. We also have additional field testing going on that is not funded. So you can, of course, field test without any funds. And we're really, really happy to receive your feedback and to hear from you if you are field testing the toolkit. So the ones that we know of for the moment are Kurdistan region of Iraq, UNHCR, Chad, WHO and MOH, Burundi, HealthNet, TPO, Ethiopia, UNHCR and IMC, Albania, WHO and UNICEF, and Greece, WHO and the, I don't know which ministry that was anymore, and Yemen, WHO. So please get in touch if you're field testing. Yes. So in this, just to mention, we're really trying to cover a lot of geographic regions and populations. The more, the better. And now.
Yeah, and so where would you like to go to next year? Will you continue with the technical support for field testing? Let's remember, it's we are in a phase of field testing, so feedback is very important. It is still a document that's open for change, adaptations. This is too much, this is too less, we need additional thing. This is the moment. And we are going to finalize this based on the feedback that we receive. And next one. And then, what are the main challenges? So we decided in Kenai that we would, instead of exploring like challenge, a request that we have for the reference group members. Who here have actually opened the toolkit and actually tried to see in a particular context how to use it? Just a few, yeah, no? A few people? Good, good. Really try it. It's very important. This document is very operational. It's relevant for everyone. So this is not one more document. It's a very operational document. And we really encourage everyone to use it, to try it, and then give this feedback. Are there missing elements? Not only from the toolkit itself, but what could we derivate from the toolkit? Are there additional things we would like to have? Perhaps some creative mechanisms for training or creative mechanisms for using the toolkit. Please do share the ideas of how to make it more friendly. Or, let's say, the experience of adapting it according to the different contexts, but also the target groups. And I was actually coming out from Ukraine, and I visited a psychiatric hospital. So I did go to the toolkit, so I should provide some feedback already of things that was helpful or not helpful. And that is very essential. And that is the process that we would like to have from all of you. Even at the end of the presentation here, if there is a space, we would like to hear here and now feedbacks that you might have. And please send it to us. There is this link where we are collecting the feedback, and always very welcome to receive a message directly as well.
Yes, so in short, we would like to continue the thematic group because of the timeline. Our field testing phase goes under around February of next year. Then we'll have discussions and lessons learned around the spring and summer, where the thematic working group again will be very involved in helping us make decisions based on feedback. There might be some feedback that's contradictory or where we have to dig a bit deeper to figure out what do we make of that, and the thematic group members will be very instrumental in that. We'll also have then revision in the summer, fall, and plan to submit for IASC approval before the end of 2025, of course also going through the rounds of feedback from IASC reference group members. Yes, and just since we still have a few minutes, since also not all of you raised your hands and actually having opened the toolkit, I want to encourage you to open it. There are lots of amazing things in there. It's not just me saying that. Actually, Rita, who we mentioned in Yemen, said she opened it and she just wanted to take a quick look, but then she kept reading because she found so many useful things in there. We have a brief introduction. We have the steps of an MHPSS assessment. For example, how do you go about it? What do you do first, like desktop review, see what's being done. One of the other crucial steps is sharing the assessment through technical working groups, for example. That's a step that's often missed, but very, very important. And sharing it also with us so we can put it in the assessment repository. It doesn't mean you have to share your assessment from the beginning to end and every single word. You can share a shortened version. You can share one page. You can share PowerPoint. Just information that you're comfortable sharing that could help others who might find it useful. Tips on integrating MHPSS into sectoral and cross-sectoral assessments. So many times you hear sectors are doing assessments or AoRs, nutrition is doing an assessment, health. How do we jump in there and make sure MHPSS is there? This toolkit actually tells you which sectoral assessments exist. Where is MHPSS already integrated? So if you hear, say somebody is doing a HERAMS health assessment, you say, oh, they're the mental health parts of the assessment. Let's double check that they're including those parts, and let's get that information from them. It also suggests going one step further. If sectors or AoRs or areas of work are open to it, maybe you can, sometimes they say, yes, just give us one question, or just, okay, 2 questions we can include. So it has some suggestions for that as well. And chapter 4, very exciting, the actual assessment tools. Yes, look at that, it's quite a lot, but it's organized into different things, and many of the tools actually have simplified versions and comprehensive versions. So this is kind of how we reacted to the feedback that people say, well, sometimes I have a day and sometimes I have 3 months, so I need tools for both. So for example, for desktop review, we have a brief and comprehensive version. We have mapping, we have simplified versions, and it's also comprehensive version, which, by the way, is consistent now with the MSP gap analysis. We often got questions like, how does the 4 Ws relate to the MSP gap analysis? There is your answer. This is what you use. The assessment toolkit comprehensive mapping tells you what you need to know and what data you need to collect for what kind of mapping. Like, you need it for advocacy, you need it for referral pathways. Depending on why you're doing the mapping, there's specific data that you will need. Household surveys, we're not establishing prevalence rates, but we are getting a sense for people's levels of distress and whether they have access to help. So that part is very important. Do people know where to go? What are the barriers to receiving care? Community and stakeholder perceptions, also very important. This time also with much support from UNICEF and others, we really included children in there and youth, which is also very new compared to previous assessment toolkit versions, including also considerations for children and adolescents. Interviews with service providers, tool guide for speaking with people with lived experience. also very important, not included so far, but very important also from the rights perspectives. Facility levels, we used to have just psychiatric hospitals and general health care. Now we have schools, community centers, camps, so we widen it out, and you can even just adapt the checklist to whatever site or setting you're going. If your specific site is not included there, you can pick one of the checklists that's close and adapt it. And I should mention that's one of the other key important things about this, that on the website you can download each of these tools in Word. So you do not have to copy and paste from PDF, because we assume that you will make changes. And that is okay, and that is a good thing, because you need to adapt, contextualize, make it so that it fits your needs and uses the right terms and information from that population. Lastly, please get in touch with us, Marcio and myself, for either support, feedback. We're always very happy to hear from you. Thank you so much.
Oh, I see a few hands already. Yes, let's take about 3 or 4 questions before we move on to the next group.
Thank you. This is fantastic. Just a few questions and points. So one, I'm curious if you think there are ways that we can reach out to academia to get them to access the assessment tool repository. I think it would be really important to have people have access to this beyond our little sphere. There have been a lot of things that I have been a part of this past year or the last few years from the academia side or the research side. So this is maybe another point, if we can put it in the parking lot for thinking about things going forward, about how is there a way that we can involve researchers more as a part of our wider efforts and kind of draw them into the fold. I don't know what that looks like, but I think there's huge intersection here. And the last thing is, just for everyone, actually, I found the graphic that shows kind of, I think there's like 9 content areas that I think it aligns with this, but I have found that extremely helpful for trying to advocate within my own organization, especially when I'm trying to convince country offices on very quick notice to say, look at how helpful this could be for you. I screenshotted that graphic, put it on a slide, and I think it's a really nice hook. So just to kind of both appreciate and recommend. Thank you.
Thank you. Thank you very much. I saw a few hands back here. Are they gone?
Okay. Now, brief 2 points. One is that, to be clear, the old 2012 assessment toolkit of WHO and UNHCR is replaced by this one. This is what just someone asked me. So, but basically, this is the go-to document for all sectors. That's the idea. And secondly, I'm very happy with the work that World Vision is doing in for example, Chad with the assessment. It's nice to do a multi-sectoral assessment. It's even nicer, but more complicated, to do also a multi-agency assessment, which is exactly what's happening in Chad. It takes more time, and it's complicated, with 4 agencies together do one assessment, but I think it will make it stronger, because we still see that each agency does its own assessment. And it helps, of course, if we use the same tools, but it would even be better if we can just make consolidated assessments.
Thank you. Great tool. I love it already, the assessment tool. It's one of the big pieces of work we've had. A question I have is how this links to the humanitarian program cycle tool and how that links to the M&E framework, particularly around defining the PIN, the persons in need, because this is where I don't get it within my own agency because I'm not part of the UN humanitarian system as Red Cross, but a lot of agencies need to know how to calculate the person in need part to plug that into humanitarian response plans, and that's where a lot of questions come up, and those 3 documents have to speak to each other if they're not already, and if they are, great.
Then there was the last question here. Oh, the same question. Well, I start with the first part and then leave it is a very interesting point, and in terms of how to include the academia or the research component, and that was a lot of our discussions at the beginning as well in terms of the scope of this exercise. if, like, for example, the studies, no, there are so many front studies when we think about so many contexts and that so many articles that has been produced and that are not directly necessarily related to mental health and sexual support, but perfectly fits under the umbrella of mental health and sexual support, right? So that's an interesting question to kind of, for further engagement and involvement when we are building also a repository that can be country-specific and be collecting all articles and elements that are relevant to that particular context as well. But it's a valid point because this is also an exercise of this multi-sectoral toolkit, speaking very much with the humanitarian context and emergency response.
Yes, and I'm just going to try to remember all the questions. Very good questions. Academia, yes, we should connect to them. I completely agree. Let's talk about also with MHPSS.net, like how can we do that? What's the best way? Maybe you guys have some ideas as well. So let's follow up on it. I think it's critical because indeed often people come in and they don't have the background that they could have because there's this disconnect. Regarding connecting documents, yes, they are absolutely connected. So we have the assessment toolkit, and Michelle Engels is actually the consultant who led on the assessment toolkit and the HPC guide, both. And initially, actually, we had the idea of making the HPC guide an appendix of the toolkit because there was so much overlap. And we eventually decided to make it its own document because it wasn't just about assessment, it was about the whole cycle. But we actually had discussions about what do we put where? Like, do we put this in the toolkit or do we put this in the HPC guide? So we're still open to feedback on where to put what, because indeed we had to make these decisions. The people in need calculation is now in the assessment toolkit, but there's also information on people in need in the HPC guide because there's indeed this overlap. And we want to hear your feedback about if this meets your needs or if there's something confusing or something we should do better. Also the M&E, you heard yesterday about the M&E indicator bank, which is very much linked to the IASC M&E framework and pulls out indicators for the MSP activities. What it also has is what I call pooled indicators, or you can say general indicators that can be reported, for example, by health about MHPSS, by GBV about MHPSS, because that's the question you often get as well. What indicators do you have on the humanitarian response? And these suggested indicators are in the MSP indicator bank. They're general indicators that can be reported across the response. And these are the same indicators that are in the HPC guide. So we just took them. And we're also open on feedback on these indicators. So please, they're not written in stone. If you have thoughts on them, please do get in touch with us. Yeah.
And there is one last point, final point from my side, is that when we were building and updating this document, we had interviews with a number of people from the academia as well, but especially with the agencies. And now we have this as a result of this exercise. It would be very interesting and we would be extremely grateful because here there are agencies that are extremely operational and they have their own way of doing needs assessments in different contexts. So it would be very interesting to receive the feedback from those agencies that have its own methodologies and format, IFRC, I don't know, RCRC, etc., that could look and make contributions with the understanding and the scope that this is a global tool. So it's not like one agency tool and that's going to always speak with your agency, but that feedback would be extremely useful.
I got the 36 last seconds. So it's the feedback. So looking at the site, which it looks great, it doesn't have a category of emergency saying climate change driven emergency. So I think that is a really interesting point, and I'm sure that it's a big point, so you don't have to answer it now, but just raising that, and maybe that's an area for work.
Thank you. Matthew, I think some of the questions we can take during break because we are running out of time a bit. Thank you so much to the mapping and assessment team. I don't know how we are doing for time, but I think the next a group that is going to present is Livelihoods and Cash. That's by Annie and Amal. Thank you so much. What a great document. If you can just popularize it within organizations, I think we'll be doing some great work. In my previous life, I used to work for an organization that said data is king. And I think with this, we are able to generate that as much as possible. Annie?
Hi, thank you. Where's the slides? Hi, everyone. I'm Annie from IASC, and I'm here with Amal from IOM. We are co-chairs. Amal has just joined the co-chair role, like last week. So we will not look to her for points on the slides, but she's joining me to support. So just to say, I think for framing, this group it's just finished its second year. And similar to some of the other groups, I think, that were discussed yesterday, we have quite a few observers. So we have great participation from members here, but also quite a few observers. And the interesting thing as well is that one of the observers has taken an outsized role, Columbia University, Claire Green. So she's been a very key supporter in some of the deliverables for this group. So I just wanted to start because she very much wanted to be here. So I'm going to go into a bit of detail. I'll try not to go too deep, but one of the key things that I wanted to highlight for today, that we wanted to highlight for today, is the work around this mapping that we set out to do to really understand the types of integrated supports, the types of integrated interventions between MHPSS and economic interventions. We really wanted to learn more about what those perceptions are, what's happening, but what perceptions are as well, and lessons learned. So you may remember last year during the meeting, I put up a QR code. I invited you to participate in a survey. So we had some good responses. Where we started was a desk review, which Claire supported with some students. And then we went to the survey. The third step following the survey was to look into key stakeholder interviews. I'm going to go through a little bit more content in this, hopefully just to give you an understanding so far of what we've learned. But really what we've looked to do is to develop a report, which I'll talk a little bit more about as well. We're not quite sure yet what to do with that report. So the desk review started with, of course, reviews of the academic and gray literature, as you would imagine. The organizational survey, we had 35 respondents that fully completed the survey. So we had more than that participated, but only 35 that completed. And then the semi-structured key informant interviews, which I'm actually going to dig into, and I'll come back to this first slide in a second. So the survey and then the key stakeholder interviews, just to highlight a few things. So the survey you'll see here really was about 50% of UN staff, 50% INGO. And there were questions around barriers and facilitators. So you'll see some of the barriers that were highlighted in the survey. Funding priorities and mandates, lack of prioritization, institutional organizational dynamics, and coordination or operational difficulties. And also interesting were that half of the people that completed the survey were actually aware of quite a few resources already. So one that was highlighted especially was IOM's guide for MHPSS and livelihood interventions, also the community-based guidance that was developed by this group, by IAS, with endorsement. Several other guides as well, that MSP, of course, but several others that had aspects of economic interventions that people were referencing. And then interesting also was to look at what people actually integrated in terms of interventions. So some of the areas that were highlighted were the family and community supports, as well as psychological first aid. And then on the livelihood side, skills training and cash-based interventions, which this is a very broad category, but I can dig into further details if there's questions. And then you'll see on the left-hand side, reasons your organization has not integrated. And there was a pretty wide range of this. I've mentioned some. And some of this came out a little bit more in the semi-structured interviews. So I'm going to talk through some of what we think the implications or recommendations are based on the stakeholder interviews and the survey. But I think it's interesting also just to mention a few key points. Overall, participants perceived that there could be improvement for both MHPSS and livelihoods outcomes. So this is interesting because sometimes we perceive that it's only the well-being that might be increased, or maybe it's only on the livelihood side that we might see increases. We also heard that it's equally important to communities as well as organizations, and that there could be an increase in resource allocation depending on how it's integrated, and that this could be very important for funders and donors. Interesting as well is that there were discussions about how it could be integrated into either side. So what would MHPSS look like if it was integrated into the economic intervention, and vice versa? What would it look like for economic to be into the MHPSS intervention? And discussions around how can we have a standardized framework that connects these outcomes better. So just a few things. I'm going to talk through practice, research, and policy. So on the practice side, one of the things that we think that would be really useful is to look at mechanisms to better coordinate and collaborate. And this is something we've talked about a lot in our meetings, which Philip, who's here, can speak to as well. But also thinking about how to utilize participatory approaches and adaptable, flexible models of implementation for these interventions. On the policy side, we think there could be better operational guidance to improve consistency in terminology and adaptable guidelines for implementing the programming, as well as multi-sectoral and flexible funding. And then on the research side, which is something that I spoke to a little bit, but I find really fascinating, is that looking at the measurement and especially the outcomes that really we don't have standardization on. So just as an example, commonly measured MHPSS outcomes that were highlighted included coping skills, mood and anxiety symptoms, resilience, self-esteem, efficacy, confidence, and subjective well-being. Whereas on the economic side, generally income, savings, expenditures, wealth, financial autonomy, employment, engagement, and income generating activities. So a pretty big range of what we're looking at. So overall, conclusions from the report, which is still in draft stage, but hopefully will reach you soon. We've really looked at, overall, there seems to be broad support for this work across humanitarian settings. There are definitely barriers, which I've named a few. There are efforts to look at how to create more visibility and uptake of the resources that exist. But we really think there needs to be further evaluation and probably more standardized, streamlined approaches to looking at evaluation across these two sectors. There's also really good conversation around cost efficiency and effectiveness, which I think probably everyone here has comments on. So that's the report, and that's just one aspect of the group, but it's been a very big aspect. It's something we've spent a great deal of time trying to figure out timing for the stakeholder interviews, trying to understand what we're going to do with the contextual pieces that we've understood. We have a draft report, it's long. We're trying to figure out what we're going to do with it, either from an advocacy perspective and or operational perspective, but that's kind of a piece I think that we'll be working on in the coming months. Also, just to mention, we tried to also promote learning events on this topic, and we had lots of interest and engagement from many of you in this room. So we were able to launch 2 this year. One was highlighting the work of GIZ, thank you, Philip, and IOM, thank you, Gullian Amal. And the other was focused on some research that IASC has conducted with Colombia in partnership with PAHO and UNHCR in Ecuador. So both of those were quite well attended, and we had multiple languages available, and we've had requests for more. So that's something that we see as a major success, but also opportunity. I should also say that we have great attendance, and I've heard this from a few groups, we have great attendance, and we have a lot of interest in thinking about what's next. So we'd like to finalize this report and figure out what to do with it. We'd also like to continue these types of learning events and series to see what other questions we can address and who can help us kind of illustrate programming. We don't have any funding, so this has all been pro bono, pro bono work by our key partner at Columbia. Claire also works with IASC on several other research projects, so it's been kind of a piece that we've been able to link with some of our other economic-facing research that we're doing with her. There's also been discussion about how to better incorporate livelihood sectors more broadly. So even beyond cash, we've had some really good engagement from the cash sector. But I think thinking about how to pull in those agencies to help us talk through challenges and opportunities in greater nuance, especially from that sectoral perspective, which we don't always have. And the other challenge has been trying to narrow a bit the scope and think about what's feasible, what's deliverable, what can we really address given our limited mandate and what we're capable of doing within the group without funding. So we would like to continue, at least at a minimum, to finish this report and figure out how we want to launch it, what we want to do with it, what perhaps next steps could look like. But we do think there probably could be a second step to that, or a third step as well, in terms of how we share that out across the broader community, not just within MHPSS and protection, but more broadly across the humanitarian community. And yes, there's a big request from the community, not the community of practice, but a big request to continue these discussions in whatever forum this looks like, whether it's here or elsewhere. But finding that space, I think, to help us find solutions to what we know is a really integral part of people's lives, to sustaining their livelihoods, we see as really core to the work of helping people be well. Okay, I'll stop there. Anything to add, IOM? No.
Maybe just one question, one burning question if anyone has, because we are kind of running behind schedule. Could we? When I said a burning question, all the hands went down, so maybe.
Just mentioning, three things. There is a renewed interest by the Carter Institute, to look into it, and with the imminent death of Jimmy Carter, because, he's one of them, maybe they will have funding even attached to it. I'm joking, but that's something we can look into, and also the World Bank has a renewed interest. So as soon as the report is ready, we should really work on it. Just to mention that today on the Journal of Peace Building and Development, we published the first report on the psychological outcomes, psychosocial outcomes, of an integrated program in Iraq, and it was peer-reviewed and published there. So that's, a good development. And we are about to publish the first report on the outcome on the livelihood itself, so basically, which showed basically improvement. This is in Somalia. And showed improvement in saving and capacity to withhold the stressful situation at work. So to keep the job if you integrate the two sectors. So
that's fantastic, Guli, because HIASC just published as well on some similar research in Ecuador that was also showing some improvements in social networks and connections, but also really improved mental health and well-being as well. So it's exciting to hear all this happening at the same time. Anything else?
Great, thank you. Maybe for the, sorry?
Can we do one more question? Please.
Can we do that over break, please, so that we allow the next group kindly to also have a chance to present? Thank you. All the ones that had the questions, please catch Annie and Amal over break to just go over some of the issues. The next group is men and boys, and they did not ask for too much time. So men and boys, that's Guli and oh, it's only you presenting, all right. Thank you very much. There you go.
So basically, this group has a very strange story, in the sense that probably it seemed like to be more an individual initiative. Then I tried to give it up, several times, but then the group here say, no, we want it, it's so necessary. And then no one shows up, at the follow-up meetings, so it's a bit complicated. So basically, just a question for you, so I want to ask you a question is, how many of you measure beneficiaries with a gender differentiation in your programs? Can you raise your hand? All of you, most of you. No? What is the proportion between men and women among your beneficiaries? Lower. Men is lower. We put quite a lot of attention into it, for instance, in the program in Ukraine, in the last 2 years. So in our preventative programs, level 3, level 2 and level 3, let's say kind of programs, men are 35% of our beneficiaries, 35 at best. And the big boost, on this came from our emotional hotline, because if you look at community-based activities, they're even lower. So what makes the difference is the online system, for counseling. If we look at specialized services, the referral to specialized services, the proportion changes. So men are much more sent to especially psychiatrical care than women. Because that's not surprising, because they arrive to the crisis point and then they are referred. So there is a big issue there that we tend not to look into at all, just because we are very attached to a discourse that prioritizes women and children in responses, and it's a discourse that is very difficult to untangle from an humanitarian perspective because of protection, because of other things. I invite you to do the same kind of evaluations in your programs, because there is a gap. So based on that, also because we work with migrants, and very often, migrants are not single, but unaccompanied men that travel, and then they bring the family with them. So we are very often confronted with men in distress that are not used to ask for help. So because of this reason, a few years ago, we established a group. There was a very good moment at the very beginning, this was 2021, where we developed a series of webinars that were very, very interesting and also very much followed. So we had hundreds and hundreds of people participating to the webinars because it was a hot topic. Most of the webinars didn't come from us, so it wasn't the humanitarian community really able to respond to most of the questions, but other actors. Some actors in the humanitarian community that are not part of this discussion, like Interpeace, like Promundo. So those are organizations that has always worked on masculinity, toxic masculinity, and help-seeking behavior, but also a lot of work came, from the States on access of Afro-American men to mental health services, and things of the sort. So it was a quite interesting, perspective. Therefore, from there, we wanted to develop a consent note, and we developed it. This was to understand current practices, to identify best practices, and identify challenges to implement at the local level. So what were the discussions? We did it, so a concept note exists, and then nothing has really happened out of that. The group is composed really of 3 agencies. So it's IOM, is the Jesuit IASC, and it's War Child, Holland, but again, so also we started delegating the responsibility and so on and so forth. So this year nothing really happened, with the group. So they met, a few times, just going around and looking for things. So there was a discussion last time if we should continue with this group, if this should become a discussion group out of the Interagency Standing Committee space, which I think will be a pity, but it's probably a necessity given that there are not enough actors, in this room. And the other issue, for me is, do we see a need? And I think there is a need. So that's the point. And why then we are so reluctant in addressing the need? That's my, my overarching question, in all this. If we decide to have the group, probably we will need to look for resources for a dedicated consultant. For me, that's, that will be the case. Also, this is not about LGBTIQ. Because, then the discussion always, when we talk about mental health for men and boys, go to somehow to, first of all, LGBTIQ community is much more than men and boys, but, that's only the G part. But, the point is not that, The point is that we are talking about the normal, and sorry for the normal word, obviously. I'm pre-walk, so that's it. I mean, it's about the usual men that move, from one place to another, or, is, involved in a war and doesn't want, to seek for help because he doesn't think this fits with his role, is reluctant, to use. And it's true that also encounter services that are, for the most part, designed for women and children and not for him. Where we see improvements, as I said, in participation of men is in the integration of livelihood and MHPSS activities. That's, a very strict link because they see it more related with what, it should be their role in society, and in, as I said, online tools, because probably there is not the social shame of being seen seeking for help. So these are the two that we see in our programs working. But then, again, if there is an interest, we are happy to continue and to look for funds together. Otherwise, we probably will bring the discussion out of this space, you know, if there are not enough agencies, you know, to continue. That's why, obviously, I wasn't even involved at all, you know, in this group for this year. So it was Karen Carpio from our side, you know, and Amy from IAS, basically leading the conversation. And they asked me to, you know, since I was here, to convey this message also because they thought I could be a stronger advocate, which I'm not sure. Okay, that's it.
Thank you, Goodley. Thank you. Yeah, a few questions, but also maybe just before the questions, particularly on the health-seeking behavior for men that you've just mentioned. And we have a colleague with us, Moses from JRS, who's doing his research on suicide and suicide prevention. Maybe I'm not even saying it right. He's doing his PhD on that. And we've worked with him previously on some of these issues, especially on suicide in the humanitarian settings. What we did find out was that in the data that we're able to collect on different countries, there are so many women who will attempt suicide, but then you have more men who die by suicide. So just to validate what he was saying in terms of by the time they're going to seek for help, they really are over the top with the support that they need. Thank you.
Yeah, this, I think, you know, it's not only in the humanitarian setting, I think it's the general suicide trajectory.
No, in the spirit of participation of people with lived experience and also nothing about us without us, can we have more representation of men and boys and sharing and participants of the men and boys group?
Okay, great.
No, sometimes, again, go back to integration. I wonder about the family and child, the family group, that, you know, whether or not there's a piece of it that actually talks about the engagement of fathers and the engagement of men in the family and child thematic group. And it was not mentioned. But for me, I mean, I think that men and boys is a multifaceted issue. And the engagement in family is often a major issue. I mean, I'm a family therapist by training, and I do a lot of clinical support in that, and constantly saying to people, where are the fathers? Why aren't they here? And I constantly have people go, oh, they won't come. And then when we really work at it, they do come. All right, we run a whole group for boys that are in gangs, as an example. And my team is an all-male team. And they wanted to work with mothers, and I absolutely refused. I said, you're going to cause us nothing but trouble if you go work with all these mothers. So I said, I want you to go find the fathers. And they did. And they ended up starting all these incredible groups with fathers just by putting an effort into engagement. So I mean, do we need a separate group? I'm not sure. I mean, I think you've had a hard time with it. But I do think that we need to be sure that there's an engagement in the other groups that doesn't just look at women and girls, and that is understanding that we have to work at the engagement of men in all the other groups as well.
This is a point. You know, the reality is that most of what is produced disregard men and boys. Also in the caregiving, you know, in the caregiving sector. This is historically what is happening. If you look at tools, yeah, it's not happening. Yeah. So that's why, you know, there was the necessity, you know, and also we are not only talking about caregivers, you know.
All right, maybe just one more question before we get to break. And then maybe the others we can engage over break time.
It's just a reflection in terms of, because obviously I work for UNFPA and we do GBV, et cetera, and I think that there is a reflection which I myself struggle in terms of going further on what it means gender and actually operationalizing gender in general in all the activities we do, just not saying like separating women and girls and men and how we count figures, but actually what does it mean when we ask questions about help-seeking behaviors on men and boys in different communities and men and women and girls, because I think that even myself, when I'm trying to operationalize assessments to be integrated in MHPSS for gender-based violence on women and girls at risk, is where I'm struggling, is to have like specific questions that actually capture those specific needs on women and girls and not say like gender sensitive, blah, blah, blah. Because I think that that's the problem. And I think that it reflects with this, and I completely agree. And I don't know if it's more about how do we actually go further when we talk about gender, basically, in terms of questions, activities, etc., etc. Just a reflection.
Thank you very much. There's a... Blame her for your short break next.
Just to quickly say, I followed the webinar series in 2021 and 2022, and I really appreciated the work of the group. And if I had more time myself, I would be happy to join. But I echo sort of what Nancy had said about the possibility to integrate some of the questions here maybe into the family group. But I also wonder if it's a point for advocacy, because I think what I certainly continue to see is, you encounter you're writing a call for proposals and you're responding, and you see specific sections around like, and how will your action address the needs of women and girls and women and children. And so I think there's just also a need in general by the entire community, the people writing the calls for proposals, to even sort of consider this as a distinct and a particular need that needs to be addressed with a specific approach.
Thank you very much. Thank you, Guli. Thank you, colleagues, for contributing on this topic. Very, very important. Let's continue talking about it at break, which we now have 17 minutes for. See you back at 11.
Now called the MHPSS Surge Mechanism. Yeah, and we're also involved because we started in 2020. As you all know, there were a lot less active technical working groups. And we also noticed there was a gap in the expertise, in the amount of experts that we could deploy as coordinators of technical working groups, because that was our first premium focus, coordination of technical working groups. So we decided to focus on training, to provide training for MHPSS experts, to also create a larger group of people with expertise, particularly in that field. This is what the structure of the mechanism looks like. So we have received funding from the Ministry of Foreign Affairs and BHA. The MHPSS Surge Mechanism is embedded in RVO, which is a Dutch acronym, but it's a Dutch government implementing agency. So even within that agency, I'm a bit of a rare program, so no one knows actually what I'm doing. But so the link with RVO is quite small, but that's where I work, and that's where you hear the name RVO come up more times. We receive requests from the requesting agencies. Could be UN, could be NGOs. We deploy experts all over the world. We don't have a fixed list of countries that we can work in. So it's up on request. And we work very closely together with the reference group co-chairs for advice and support, both to our program, but also to the experts that are deployed. And as you all know, we have a new collaboration with the regional focal points, so Cecile and Marcio for the Lusophone countries. So that also really provides extra support to different contexts. These are the current partnerships that we have agreements with as RVO. Next to the MHPSS Surge Mechanism, we also have a mechanism within RVO on WASH and DRR. So together with that program, we have set agreements with various UN agencies, and we can support them on both topics. But for example, ACF, we've only been working together on MHPSS deployment so far. And for example, with UNDP, we've only worked on WASH deployments so far, but the agreement is set, so we can always deploy experts with that organization. But I just want to clarify, we don't need agreements to be able to deploy experts to an organization. It's just that within this agreement, we agree on what the roles are of the different agencies. So what are we responsible for? What are the hosting agencies responsible for? And what if something happens, how do we deal with it? So that's why we have these agreements. And for a lot of organizations, they really appreciate it and they need it actually to be able to host someone. But from our side, we are open to work with any agency. As long, and I forgot to mention this actually, one of the main criteria for deployments is that it's interagency support. So we don't support the actual work of one agency, but it should be led, co-led by several agencies within a technical working group. We are currently in discussion with Save the Children and IMC for agreements, to set up agreements to be able to deploy experts with these organizations as well. So what is our support to deployees? So we provide a contracting, which includes a daily fee, so a salary, and cost recovery, so for example, flight, accommodation, DSA, etc. We provide personal support, psychosocial support, so we work together with Antares Foundation for that, and technical support, both through the MHPSS network that they are embedded in when they're deployed with us, as Fami already, or I think Terry already mentioned this WhatsApp group of experts, previous deployed and current deployed experts, for peer-to-peer support, but also, of course, the continuous support of the reference group co-chairs. And that is, yeah, I'll go over that later. Like I said, we also have training modules, and we provide insurance. And like the example that I gave yesterday, sometimes that's a bit more difficult, but we always have an insurance for an expert in place, otherwise we won't deploy someone, because we really care about the duty of care. So this might be interesting to give you a bit of an overview of what the different roles and responsibilities are. So, like I said, this is actually a summary of what I just explained, but also what the hosting agency is responsible for. So we expect a hosting agency to really take care and embed a person in their organization. We provide the daily fee, we provide all the costs, but they need to make sure there's a desk available for them at the office, that they are embedded in the security structures of the hosting agency and all those kind of aspects. Also, local transportation is something that they need to cover. And for example, very practical airport pickup and all those kind of things. And support with accommodation is more like it should fit their security guidelines. So they don't need to pay for it, but they need to support us in where can someone stay and all those practical things. Regarding security, all deployed expert needs to do a Be Safe training. But in addition, so for example, we have someone in Somalia at the moment, and upon arrival, she had to do a heat training because that was required by the hosting agency. So that is only for a certain context, not for every deployment. They need to go through a heat training, but that's always upon discussion with the hosting agency. We provide a duty of care, monthly check-ins, but the hosting agency has a daily supervisor, someone who's at the desk, not necessarily an MHPSS expert. Sometimes they don't have someone specifically for MHPSS at the country office, and that's why a deployee comes in. But it should be someone who's responsible for it and could support an expert in all aspects during the deployment. Yeah, and in case of R&R, the hosting agency is responsible for the flight costs. Yeah. And this also might clarify some questions. So this is an example of how a deployment request goes. So we receive a request. Sometimes we get in touch with the country office to further discuss a request because we can think along or they have questions on it. But if we agree on the request, we set it out in our database and we select experts, and the final selection is always done by the hosting agency. So we propose experts and they select. We make sure that all the briefings are in place, the security briefings, the Antares briefing for their own well-being, insurance and everything, their flights is ready. And then we're deployed. They're always regularly in touch with the different support structures. And after deployment, We always organize a debriefing just to learn from a deployment and also to see what follow-up is needed. Yeah, and it really depends on the context. So for remote deployments, we don't set up a debrief with Antares, for example. But for, usually we advise experts to organize or to talk with Antares after deployments. But in some cases, we actually organize it, set it up for them because we feel it's quite necessary, depending on the context. And this, well, some statistics of our program since 2020. So we've had 60 deployments so far, but also 34 extensions. So that is added to the 60 original deployments. And those extensions usually vary between 4 weeks to 3 months. We've been involved in 23 trainings. So, for example, ourselves, we organized a code of conduct training or communication training. We set up MHPSS coordination trainings, but also simulation exercises. And then we had experts from our roster participate in trainings of other agencies, such as child protection in emergencies or mental health in complex emergencies with Marcio. So it's with Fordham University. So we also collaborate with other institutes and agencies to expand our database and expertise. We have 426 experts in the database at the moment. They're not under contract with us. It's a database where we can set out requests. So they haven't all been deployed yet, but we're kind of building on this database and improving the expertise in the database. So far, we're doing quite well on the gender balance. So we had 33 deployments were filled in by a man and 27 by a woman. It's not 33 men have been deployed because some people have been deployed twice. But this is just how the 60 deployments have been filled in. And the same counts for this graphic. So 38 of the deployments have been filled in by European experts, but also quite a large number were experts from Africa or the MENA region, some from North America, and one person from South America. These are the countries that we've worked in so far. So this is an overview, and below I added, we had one deployment that supported a regional, was a regional supporting position for the Francophone countries in Africa. Most of these deployments have been in-country, but some have been remote because, as you realize, we've been working since 2020 during all the lockdowns and the COVID crisis. So some have been remote deployments, but most in-country. These have been the hosting agencies. So most from WHO, but also a lot from other UN agencies, and 3 deployments with ACF. And I wanted to share some successes. So we haven't, we don't have information from follow-ups of all the deployments, but what we have noticed, or what we have collected in terms of information is that 14 experts, so 14 deployments ended with the expert being contracted directly in that role by the organization. So they continued their work without our funding. And usually that was, so there wasn't a position before the deployment, and then the organizations created a position and actually continued with the expert. And like Fami and Terry, I think yesterday already mentioned, it's a pity for us because we lose good experts. But then again, it's one of the successes of our program that they're valued and that the work is appreciated. 6 deployments ended with secured funding for the position, but not filled in by our expert due to various reasons. They had other contracts, or they had wanted to hire a local expert. And we had quite some positive feedback on the training opportunities. To give you an example, we had we set out an invitation for that people could apply for a simulation training. We had 20 spots available, 21 spots available, and I think we got over 130 candidates applying. So it's quite impressive. We also had some challenges, so logistically speaking, in terms of visa applications, quarantines. Terry can tell more about that. But also that a hosting organization didn't have a workplace available, so there was no free desk, for example, or I wrote down some other examples. So the time difference, so we had a remote deployment with a huge time difference, and the country office didn't really accommodate with the meeting hours, so it was, those challenges exist. We also had challenges with security, and Gaza is the clearest example of that. We couldn't deploy the expert ourselves with our insurance company because they couldn't cover his deployment, so that's why we collaborate with Canada, that they had an insurance company that could actually secure the insurance for that expert. And we also had a challenge with functioning of experts. So I think, as far as I'm aware, there were 2 experts that didn't really meet up with the expectations. And then we just got in touch with the hosting organizations. We provide extra support. And in one case, we actually ended the deployment previously. And that's also reality. And yeah, I want to end with a brief call to action. So for all agencies that are interested in working with us, contact us. We are more than happy to diversify our partners in the next year. Thank you.
Thank you, Sylvie. And great presentation and great work. Few points from the reference group side. First, RVO is a member of the reference group, so few points on our collaboration. First, Sylvie. When we started this program with the first deployment, it was Dora, I think from Portugal. She was deployed to South Sudan. The first responsible officer from what was at that time DRR Water, Dutch Surge Support, not with a new name. The responsible officer for the deployment was Sylvie. And Sylvie was promoted 2 months ago to be the responsible officer for the whole program within the Ministry of Economic Affairs and RVO. So let's congratulate Sylvie first. And thanks for all the work you have been doing. And we really appreciate all your support for this program for continuous years. I think it's a huge achievement, but it still have its own difficulties. One of the big difficulties is uncertainty. We were not sure last year if the program will continue or not. We are grateful for the Ministry of Foreign Affairs of the Netherlands for agreeing to continue supporting it until 2026. But Carmen and me traveled this year to The Hague to continue the advocacy, including in the transition you have in the first week of the change of management and at critical time of advocacy, and we were successful to work with you and continue the program until 2026. What we need to do is also look for other donors, other partners, and one of the successes we have this year was actually being represented as IASC reference group in the standby partner mechanism retreat. There was a meeting for the steering group, like there is a side meeting for the steering group of this surge mechanism. In this annual meeting, there was another one in the previous annual meeting, a side meeting for the steering group. In the steering group meeting, it is happening this evening, Guli. In the steering group for this, for the last annual meeting, we agreed that we will be represented in the standby partnership retreat. There is another group, like this group, called the SBP, where all the members, RVO is one of more than 20 other SBPs. And the idea, if you want to expand, is to go there and say, and tell them that we are a good practice. And we were selected as a good practice. Grateful to UNICEF and WHO standby partner focal points. These are HR colleagues in these 2 agencies who are holding the agenda and put this mechanism as one global good practice during the SBP network, which is just a simple annual meeting like this one we are having. We need to continue. It happened...
usually in April.
Yeah, it happened parallel to the HNPW. Another good reason why we need to continue being features in the Humanitarian Networking and Partnership Week. It's not part of the HNPW program, but as a side event, SBP usually have retreats. The way to expand is actually to talk to the other 20 partners, just like RVO. But I think we need to go deeper in the RVO collaboration, as also double hatting, because Mark is not in the room. also on behalf of WHO, and as plus co-chair of the reference group, I'm not happy that WHO requests are larger than others. But we cannot help with that, except other agencies make more requests. This is the way, and except if other agencies join the mechanism. And because we have currently mainly UN agencies, UNHCR and IOM and UNICEF and WHO, plus one NGO only. And as we have Save the Children is planning to join, IMC is planning to join. So I think unless we expand the number of agencies who can host, and it's not difficult, and also it does not require any financial cost on the hosting agency. Unless we expand, we will continue to get requests from UN agencies. And the idea is not to ask WHO to request less, especially if WHO is hosting, and is actually ask others to please request more, because we can accommodate more. Sometimes agencies do make sacrifice if you make a request, like the OPT, like Gaza one. And because OCHA has put that the program criticality would not allow us to have except one MHPSS person in whole Gaza. And the request was that if WHO hosts a person, that WHO during that period will not have a programmatic person, because our rule saying that we will not have a program. So we agreed that we will host a person inter-agency during that period, but WHO will not do a program in Gaza, will host it on behalf of the system. And I think it worked, it was useful. We had some challenges also in MHPSS and well-being. And actually this was the first year where a person, I will keep the name of the country confidential, and the name of the colleague confidential, who had a severe medical illness diagnosed during the deployment in a war zone. And we needed to do a medical evacuation. And we had to deal with all the consequences, not only of the medical illness in a war zone, but also of the mental health consequences together with Antares, and also the human element of actually supporting our colleague who was diagnosed with something very severe, affecting this person's life, his or her, during a deployment in a war zone, which was very touching for all of us. So the mental health consequence also, the MHPSS support that we get from Antares, I think is very critical. One of the issues also we need to ensure is continuous capacity building of our deployees. Because the more people get recognized that they are good, the more they get full-time recruited in agencies, the more they get exit from the system, which is not bad news for MHPSS, but difficult for us. So continuous capacity building on diversity of topics. I want to share with you, Sylvie, some frequently asked questions, and I kindly ask you to answer these questions in a brief format, concrete answer. But of course, elaborate if you think some of them need elaboration. Who pays the salary during the deployment?
We do.
Perfect. How much is the salary, and based on what do you assess?
It's a fixed amount, so it's 300 euros per working day. Mm-hmm. And travel days are also working days. So it's not for weekend days, but it's a fixed amount. So there's no discussion, unfortunately, for some experts, but yeah. It's a set amount.
That's an okay salary, but would you pay me a per diem when I get deployed with you?
Yes, you also get DSA for other costs. So that's for foods, all the other daily expenses that you might have when you're deployed in the country. And you get your accommodation cost, but that is not a fixed amount. It's just based on the actual costs, just like the flight and visa cost. You get it reimbursed. And these are all fixed amounts set by the Dutch government. So it's for me as someone who works for the Dutch government, but the same amounts count for the experts that we deploy.
And is the DSA included in my salary? And if weekends are included in DSA? These are really frequently asked questions, very important.
Yes, DSA is included for weekend days as well. It's for all the days that you're in the field.
But you deduct DSA from my salary, or salary plus DSA?
Salary plus DSA.
Thank you. Yeah, exactly. And this DSA or per diem, how much it is usually?
It really depends on the country. So it depends, there's an extensive list set by the Dutch government for each country. And then within each country, it also differs if you're, for example, in Nairobi or in Kakuma, or if you're, I don't know, it really depends. So it's set, I think, in collaboration with the Dutch embassies, they set these amounts, or based on the UN amounts. So it's generous enough.
Okay, so DSA plus the salary, and I'm insured by you or insured by the agency? If, God forbid, something happened to me during deployment, am I insured by you or the hosting agency?
By us.
By you, okay.
Yes.
Very good to know. So shall I arrange my ticket when I travel, or you book my flight ticket? And do I need to arrange my accommodation, or do you arrange my accommodation?
Very practical questions.
Yeah.
So how it usually works is someone hears that he is selected for a deployment. Then we ask that person to immediately look for flights that suit his schedule, usually within a few days. We send that flight option to the hosting agency to ask for confirmation, and then the employee can book his flight. We reimburse the costs. And for accommodation, we usually first check with the hosting agency if they have recommended accommodation. Sometimes it is in a compound, that's obligatory. And in some contexts, they just have a security guideline for accommodation, or they even have certain hotels that they usually work with. And we share that information with the employee so he or she can book his or her own accommodation.
Very good.
Yeah.
I have a Yahoo and Hotmail account. Can I continue using them, or I end up with an account by UNICEF or IOM when I get deployed?
You need to get an account of the hosting agency. And that is also something previously in the logistical challenges. Sometimes that account came a few weeks after a deployee already started. So we always request hosting agency to set up an email address immediately for an expert.
Look, this is nice benefits. I have the insurance, I have the salary, I have the ticket, I have the accommodation, I have new IOM or UNICEF or WHO email. So now I'm thinking of changing the jobs. Who will be really my supervisor when I get deployed? Will Terry be supervising me if I go to Somalia?
No, it's the hosting agency that supervises. We are providing technical support. So on a day-to-day basis, you're in contact with your supervisor at the country office. We always try to set up a brief call with the supervisor and the expert to set priorities for the next 3 months. Also for us to get to know that supervisor and to make sure that they're in line. And the hosting agency, so the supervisor fills in a performance evaluation report at the end of a deployment that an expert can also use for future applications. And Terry and Fami provides additional support. So if a deployee, he's always linked to one of them at the beginning of a deployment or even prior to a deployment. And during a deployment, they can always reach out if they have technical questions, also to the peer-to-peer network, but also to you.
Do I need to write reports, and the reports go to reference group or go to the agency or go to you?
We don't require a lot of reporting, and that is on purpose because we don't want to burden experts with a lot of extra work. What we do is we reach out every month to ask for an update, like briefly, how's it going? Do you need extra support? Is everything going well, both on personal aspects, logistical aspects, as well as on the content? If needed, we redirect someone to, for example, the co-chairs if they have technical issues that they're dealing with, or to Antares if there are personal issues that they're dealing with. At the end of a deployment, we don't expect someone to write a full report. Usually they write a handover note that we welcome. They write it for the hosting agency. We always would like to receive it just to see what they've been doing and what potential follow-up is needed from the co-chairs. But we always set up a, sorry, Fami, I'm extending a little bit on this response.
I need this information. I need it for my deployment.
We always set up a debriefing call, which is usually 1 hour. I always take a lot of notes, and that is mostly for our own learning purposes, to see what has been going well, what can we improve, what can the hosting agency improve, what can the co-chairs improve in terms of support. So we won't share those notes outside of our team, but it's just for our own learning purposes. So that we actually, instead of asking someone to write a full report, which might take a lot of time for someone, we just schedule in this 1 hour call and that's it. That's the final reporting.
Okay. Did you ever, in this deployment, has to fire or dismiss a person like me? Did it ever happen and why?
Yes, just like I said, there has been one expert that didn't function well in this position. And yeah, first we tried to support the expert with additional technical support. We worked very closely with the supervisor at the hosting agency. And in the end, in a collaborative meeting with the expert and the supervisor and us, we decided to end the deployment. And we decided to deploy another expert to be able to continue the support to the country office, which was much needed.
Very quickly, I'm getting a job and at the risk of losing it. But what about the selection process? I know Terry very well. We are friends. Can she, as a co-chair of the reference group, select me?
Well, I think if you apply, you have a high chance of getting selected. But no, the selection is not done by us. But that's mostly because of your expertise in the field, not because you're a co-chair involved in this program. Because we don't do the selection.
Yeah.
We do the pre-selection. We filter the applications. We don't send 50 applications to a hosting agency. We usually send 3 CVs saying, and the people that we send, we select them also on very practical reasons. Do they speak the right languages? Are they available on a short notice? Yeah, those kind of, and of course, also based on their CV, do they have the right experience for this position? Do we know them from one of the trainings? Like it's based on various criteria. And then we shortlist it to usually 3 CVs. We send it to the hosting agency and they can finally select someone. Sometimes they decide to do another interview with the 3 candidates, which is fine by us. And sometimes they come to us, say, do you have more other experts that are, I don't know, they have additional requests, and we do the extra search and send new CVs.
Look, I'll be very frank with you. I have a permanent job, and I cannot take a 3 to 6 months leave. Do you have type of deployments that if I don't want to go to holiday, I want to use my holiday 1 to 2 weeks, and then go to deployment with you? Can you hire me?
For 1 to 2 weeks? So far, we haven't had deployments of 1 to 2 weeks. It's usually been 3 months, sometimes a bit less, but usually 3 months.
Yeah.
We are always thinking about extending our mechanism to other type of deployments, because so far we've been focusing on coordination structures and setting it up and supporting technical working groups. But now there are more and more technical working groups that are functioning and well set up, and they need additional technical support on a certain topic. For example, implementing MSP or M&E questions, or, well, you can think of any thematic issue that they're dealing with. And we're always flexible to look with the hosting organization if they need different kind of support. But so far, we've only received requests of 3 months.
Yeah.
It happened that people are under fixed-term contract. They don't want to lose their current job, but they do want to get on this deployment. And then it's always in agreement with their organizations that they're involved with to see if they can take an unpaid leave period, for example.
However, I have a secret. I know someone here who got deployed for one of these deployments for 1 week. Only if he or she want to raise their hand and say that they did it 3 years ago. Deployed for 1 week. For 1 week. So the person one colleague got deployed for 1 week, actually, to go for capacity building workshop around 3 or 4 years ago. These deployments are feasible. I know they are feasible, but the person wants to keep their identity anonymous. So I keep it anonymous. Okay, this is very helpful. And do I need to pay to join some of your trainings? And do I need to have deployed before to join any of your trainings? Do I need to pay my per diem and ticket to join any of the training opportunities you mentioned?
Both short answers are no. You don't have to be deployed to be trained, because we always want to train people on our roster to be able to be deployed in the future. So we train them on MHPSS coordination structures, and then we deploy them, for example. And so far, the trainings that we've organized, they are fully compensated. But yeah, I don't know about the future. It might happen that there's a training where no DSA is involved, but the main costs are always reimbursed.
These are very useful information, and I'm seriously considering joining the roster.
After your co-chair period.
No, thank you, Sylvia. And colleagues, I think these are the practical information we get asked upon. I think they're very valid questions. Many of us might actually be interested or might actually explain it to others, including, please, our country offices and your SBP focal points. So you join the mechanism, so we expand the database, so the deployments are not only to UN agencies or WHO. We need colleagues. And our commitment in the next year work plan is that actually we will continue orienting SBP focal points if you're interested in orientation in your respective organization, and we'll do the same in annual meetings of the SBP to enhance the mechanism. Thank you, Sylvie. Thank you for all what RVO is doing, and thank you, colleagues.
Thank you.
Thank you so much, Sylvie. As you've learned, there's absolutely no cost to your organization. I think I would add except a mobile phone, internet connection, and maybe space. Yeah, just a very, very, very minor cost. Now we move on to the next section, where we'll be looking at the sector and AOR updates. So colleagues that are involved in that area, please come forward. I think we have protection, Peter. He's just stepped out. We have education, Allah. Health. Oh, Fami is right here. And then we have a colleague who could not join us, be with us here in person, but he sent a video a recording of some of the areas we asked him to intervene on. That's Koen. We'll be showing it at when in his allocated time. And then for GBV, we have Monica. Are they in that order? Oh, so they're in that order. Okay, great. Peter, we were asking about you. We were doing the sector updates, AOR updates. So we start with protection, Peter, followed by education. We have about 30 minutes for everybody. All the sectors. So please go ahead.
So I'll do it very brief. I'm not working for the Global Protection Cluster, but I work in UNHCR. We are hosting the Global Protection Cluster, so to be clear. Let's go to the next slides. I have 3 slides. Basically, the engagement with the Global Protection Cluster and this group dates from a few years ago. The Protection Cluster was always, I hope they're not listening, a little bit a hard cluster in the sense that they have so many things to do, and they also have these AoRs, these areas of responsibilities like child protection and GBV that do a lot of MHPSS, and the general protection was then not always that strong. We try to change that. One of the things is by making MHPSS needs more visible in assessments. That's really a change over the last years. The needs were always there, but perhaps we didn't ask about it. And now it becomes more clear. So you see that here. So in the Global Protection Update that was issued this summer, mental health needs are in the top 8 needs. That's good. At least it's a beginning. And then also if you look at the country reports, you see that almost all of them report psychological and emotional abuse or inflicted distress. The terminology is a bit more also coming from the legal background. It's really about protection risks, but we talk about MHPSS issues here. So most of them report about it, and almost more than half of them rate these risks as high or very high. This is significant because ultimately this should be translated in more action. Things are happening already, but sometimes things go slow. And to give some examples of recent protection assessments where MHPSS was really featuring quite strongly is Afghanistan. Afghanistan is a difficult working context. The protection space is really diminishing rapidly for girls and women in particular, of course. MHPSS has a bit of a special position, particularly if you frame it as a part of health, then you can still do quite a lot, which gives opportunities. Now, MHPSS is really an area where protection actors can engage with, which is good and which is risky. So there has been in Kandahar, all the MHPSS activities are shut down by the authorities because they found out that one of the GBV actors was actually doing GBV under the name of MHPSS, which is not that strange because if you talk about women who are depressed, what is it related to in Afghanistan? Very often it is related to situations of domestic abuse. But anyway, it's risky, but it's also an opportunity. So we see a lot of attention for MHPSS in the protection context in Afghanistan. Niger also quite strongly featuring, I think one of the four even. There were 4 areas that the protection cluster wants to focus on, and MHPSS is one of them, with some actions like deploying MHPSS people in protection outreach teams, which is good. And the last one is Somalia. I was very happy to see this. I think it's related to the deployment of the MHPSS support because their MHPSS is really featuring very prominently, and the recommendations are to implement the minimum service package. So I think that was interesting, and it should be like that. Yeah. Isn't it? Yeah, you see there that it also has an effect also on the protection document. So next slide. Then specific activities in the global protection cluster. They are supporting, it's small, but still it's coming, requests to deploy MHPSS experts in Yemen. We heard about it yesterday, currently talking about also in Sudan, which I think is good. They may also have some opportunities to get experts from, let's say, protection standby partners. We're talking now about with NORCAP. It's not sure whether it will happen, but it's interesting. If the protection clusters say, we need someone to help us integrate MHPSS in our work and support the technical working group. If I'm involved, I make sure it is linked to the technical working group, of course. It's helpful. Also, after the earthquake in Syria, actually, the protection cluster was very helpful, as well as I understood. Yeah. And then, of course, this is a bit cheating because the health and protection joint operational framework was published already last year, but I think it's still an achievement to really work on now what does it mean, how can the clusters work better. Next, last. What does the Global Protection Cluster want to do? First is this issue around deployees. I think that's really something to further explore. They're very keen on doing that. And the second thing is they have this field coordination kit. And there is a section, a good section on MHPSS. I don't know who of us was involved in it, but there is a draft, and I think we have to make sure that we're involved. I looked at it; it's good, but it's still good to review it. No, okay, that's what I thought. Yeah, I hadn't seen it either. So this meeting is wonderful, just to get to find out things. Because actually for coordinators of protection clusters, let me say it like that, you see variability around the engagement with MHPSS based on background. So it is good actually to have MHPSS well represented in this. There are other tools as well that were developed by the GPC in the past, how MHPSS can strengthen protection outcomes. And you have to speak the protection language to say that it's good in itself, but it's also good for protection work. It facilitates that. Well, that's about it.
Thank you very much, Peter. Any questions? Dole?
The question is a doubt and probably a possible action. So as you probably know, MHPSS in IOM now is under protection. So they brought us under the protection division. We are having challenges, that have to do with policies, the protection cluster, in 3 levels. The first one, they tend to frame us as a specialized protection area. And this seems to come from basically their own documents, so that don't look at MHPSS as a full package, but mostly as a specialized protection area. And now they are stepping more and more into what they call committee-based protection, which is basically level 2 MHPSS activities, And so I wonder if there is a discussion about it, how we can maybe Eva was thinking, a presentation, about the full MHPSS pyramid to the protection cluster, so that we intervene, let's say, before the problem then occurs, because I think they're preparing a guidance note, on what community-based protection is.
Yeah, no, I think it's an excellent idea, because there was actually, if you look, I mean, there may be other guidance documents that I don't know of, but if you look at the guidance that Sarah Harrison was involved in a few years ago on how MHPSS can strengthen protection outcomes. Oh, yes, you did. And that actually, that's not looking at MHPSS as a separate sector. We see that often, also in child protection and in GBV. We too often see that people say, no, this is not protection, we should refer to the MHPSS sector or something, these kind of things. And I say, that's making it too easy for yourself. There are things you can do as a protection actor. So I think it's good to reiterate that. So let's talk about that, Guli, and see if maybe we could either have a webinar or in the global protection cluster meeting. Yeah, okay, yeah. Terry, what should I do now?
Yeah.
Continue talking? Oh, no.
Yes, thank you. Thanks so much for these updates. It's really exciting to see all the work in this space. Also, not a question, but more of a sharing and a comment. There's the Protection Case Management Project, which has been led by NRC with the support of IRC for really ensuring an update to that and field testing version. Really excitingly, a component of that was ensuring that there's activities, MHPSS activities, and a call to action for protection case managers to have resources to be able to provide level 3 MHPSS activities as case managers. And I think that's something that's the global protection really supported with this, and there's been long-standing conversations with the focal point from NRC with that, and also support and really important inputs and discussions with CP and GBV around that, around scope of work, space, and boundaries, and also like different clients to serve or not serve and how to coordinate. So ongoing discussions, but really exciting. That'll be forthcoming soon. Yeah.
Let's make sure then that we include that if we have this capacity building work with the global protection cluster, that we also do this part.
Okay, all right. Thank you, Peter. Thank you, colleagues. Time. Just. There were a few hands that I've ignored back there, so I'm sorry, but can we have Education Ella, please? Presenting the next session. Again, please just note your questions, and then over breaks, we can keep interacting.
Hi, I'm Ala. I work with the Global Education Cluster, and luckily funded by Save the Children, Denmark, through DENIDA. And I focus on MHPSS integration within education coordination. So basically, GEC has commitment towards some of the IASC mandated cross-cutting issues. One of it is MHPSS. We did our annual meeting last month, and it was focused on learning in crisis and also trying to have collective actions from partners on how to maybe coordinate EIE in emergencies with a specific focus on social emotional learning. So Peter mentioned one thing. I will go again to talk about it in the challenges part. We need to speak the audience language. We need to speak the language of the sector we are supporting or the cluster we are supporting to understand each other. So there's some terms, especially for SEL. That's why we focused on it, because our partners and audience were pure education. I will explain quickly how MHPSS fits on our strategic objectives through GEC strategy. So when we talk about strengthening capacity for coordination, we do have Core 1, Core 2 obligatory trainings for cluster coordinators and IMs, where MHPSS was integrated within this training, and also capacity sharing with partners. For the strategic objective number 2 is the improving the quality of education and to improve the quality of education we need to assess. This will include SEL, MHPSS, learning outcomes, etc. Also, we do contribute to prepared, resilient, and education systems through anticipatory actions. So we do in education or in emergencies preparedness. We heard in the morning about DRR, and we advised to see child-friendly DRRs that has MHPSS integrated in education. We also advocate for prioritization of education in emergencies because usually it gets forgotten from day one, and we need to fight to put back education on the table. Surely we have 3 principles related to accountability, principled partnership, and also holistic approaches. I added this because I hear usually that we don't know what education is doing in regards to MHPSS or any other thematic. Where do we operate? We support the 25 IASC cluster activated countries, in addition to Syria hubs that has 3 hubs. Also, Lebanon prioritized countries with non-cluster activated, however, it's prioritized for GEC, like Lebanon and Pakistan. How do RRTs or rapid response team, including myself, that I work in coordination and also with a focus on MHPSS, how do we support the cluster coordinators? We support them through the IASC cluster core functions. There's a 6th one about resource mobilization and advocacy. I forgot to add it. So any support we give to a country, it should include MHPSS integration in support service delivery, response planning, monitoring and evaluation. So basically all the core functions that support one of the HPC maybe areas. What we did this year to clarify things and unpack back learning, what do we mean as a GEC by learning in emergencies? So we needed to unpack it to have maybe the activities clear from day one of any crisis. We had drafted a framing paper with a lot of global partners and also from SAG members. And we had a framing paper that explained what do we mean by learning anyway. In the core definition of learning in EIE, we added literacy, numeracy, and also social emotional learning as a part of like MHPSS. We had also considerations while talking about interventions or choosing activities in EIE setting. We need to have age of the learner as a core consideration. Also the strength of the education system in the country and the crisis phase or severity and level of preparedness. We can share it and it's already on our website if you wanted, the framing paper and also the visualization of the framing paper. So we agreed to have 3 scenarios. One of them is the extreme situation when access is difficult, like in Gaza, 90% of the schools are destroyed and we have protection and access issues, for example. So it's severe. What can we do as education actors from day one? We need to be providing MHPSS and some elements of foundational learning from SEL from day one. And we did link to the MSP in our framing paper. So we got one of the main texts mentioning the role of education actors from day one, and we linked it there. Sudden onset, when there's acute crisis and the system is already weak from before the crisis, we can maybe focus on basics like foundational and life-saving learning opportunities, more of EIE approaches. In protracted crisis, where we have the opportunity of having before a strong education system, here we can maybe focus on broader academic learning, digital skills, and also citizenship, peace education, etc. Next. These are the challenges and commitment to action that we discussed during our annual meeting, and also that I witnessed while supporting in MHPSS integration in the countries we support. First one is the limited cross-sectoral engagement between sectors and clusters, especially with the technical working group. We try to be Carmen in saying, no, you need to talk with the MHPSS technical working group, but in most of the contexts, they don't know that they exist. They are not aware about their role and responsibility. They don't talk to each other. So this is really a huge problem. Also, the lack of unified MHPSS language in education from global actors, country level, Ministry of Education, leading agencies. As you know, GEC is led by SAVE and UNICEF, and we still use PSS separate in our programs if we are SAVE or from UNICEF. And this create like literally a barrier to speak a unified language according to the global MSP or guidance that we have. Inflexibility in supporting local initiatives. A couple of actors mentioned that we cannot do community engagement right if we don't support local initiatives, especially in MHPSS, whether in or around the schools, because we are maybe we have more adherence to frameworks, so we cannot easily do it. Measuring SEL and localizing frameworks, none of our response plans measure social emotional learning. And it's an advocacy point we are getting from ECW, also from the MSP to measure learning and SEL outcomes. The argument was that you cannot go to a hospital without being assessed, and then you take maybe the service based on the assessment. So same for education, for learning and SEL. We need to start assessing and giving the service based on the assessed needs. We still also see partners that mix between education actors, that mix between PSS, SEL. We don't know that it's MHPSS. So it's like it's a mess. So I invite partners who has the technical knowledge in MHPSS to use the opportunity through the education cluster to target more partners and to use their technical expertise in supporting capacity sharing in education clusters. I had one about deliverables. I think it passed. I will pass 1 minute it needs. This one. Okay. I will not speak about the MSP because also we were consulted in the coordination, education coordination indicators, assessments, etc. We had drafted education HNRP thematic tip sheet through GEC before having the HPC thematic paper, and surely we can also visit it again and update according to what we have global guidance. It was a need because education actors will focus on their mandate if we use a lot of technical terms, and it's not their area of expertise. So if I have a specific tip sheet on MHPSS, no one will read it. But we work on one HNRP tip sheet where we integrated all the cross thematic issues with the same action, like include MHPSS, I don't know what, in needs assessment. So in one message, we targeted or compiled the actions, the minimum actions, let's say, that an education coordinator or IM can take to ensure integrating MHPSS. Also, we launched the MHPSS in EIE coordination e-learning module over Agora and Kaya, and it's also a mandatory training for our coordinators, IMs, to have foundational knowledge. What do we mean by MHPSS in coordination in education specifically? So it's for EIE actors, whether you are an education coordinator, sector coordinator or not. Same for IMs. We are active in the Child and Family Thematic Group and also INE, and I would like to thank really this group for always supporting in technical advice, including their members. And they were very responsive in any advice we need for technical review. Same with the INE PSS SEL, and here when I say INE, INE, PSS, SEL working group, you will notice the ununified terminologies we use. Okay, we follow the INE guidance in education, but we do want also to integrate MHPSS, but the language isn't parallel. The last one is the workshops we are organizing with INE on localization toolbox of the SEL. Also, the new minimum standard that was revised. That's done.
Okay, thank you very much.
I saw you looking at me, I was like.
No, I was just looking at you presenting. I wasn't saying anything. Thank you very much. I think because the next session is a recorded version, I'll allow, and we might not be able to ask him questions, obviously. I'll allow about 3 reactions from this section on education and MHPSS, if anyone has. Don't be afraid to speak now. I won't cut you off.
Thank you. Just a quick, we created a EIE toolkit just post-COVID, trying to pull some of this together, but we haven't actually updated a lot of those resources. So really like to connect to try and, so it's on mhpss.net on the front page. We'd really like to connect to make sure that a lot of, if there's any additional material that can be brought in from the EIE space into the MHPSS.
Sure. But when EIE, we work on EIE in coordination, literally. That's why I was like wondering, in EIE, we need, if we talk about MHPSS, to engage with INEE.
EIE is Education in Emergencies, for those who
Yeah.
are less acronym.
They have reached more than us.
Yeah. No, just to say that this is so exciting to see how strongly the education cluster is engaging with MHPSS, really more explicitly. And that just want to say that that's also what I see in refugee settings, so the non-clusterized parts, that it really is ingrained in policies on the Global Refugee Forum.
Yeah.
SAL was actually the big thing. Socio-emotional learning was really was one of the big things in the MHPSS section. So that's really good to see that. And also
we did
funders.
Sign it.
Yeah.
We signed that.
Wonderful.
Thank you. Just a huge appreciation, actually, Ella, for everything that you're doing, because I think we have seen a big impact of you bringing everyone together and coalescing around this, which was very much missing, I think, before your position. So just a huge thank you. And from the UNICEF side, I think a lot of the things that you've mentioned here have been very well picked up and used. And maybe just to mention that also UNICEF has pulled together a very short kind of, maybe more internal, but welcome to be used by other people, linkages between EIE and the MSP, just kind of like a quick sheet package that is bigger than the tip sheet, but maybe just to say we're recalling it shortly if any of you have the currently out version, because we found some wrong sign postings in there, so we'll reissue it again shortly.
I literally had 2 hours meeting to explain why we need to reference MSP in the in the learning framing paper. So it is a struggle on all levels to speak unified language. It needs time to change. That's why in cluster settings, I feel someone asked yesterday how we can engage more shelter. I find it very useful in GSC to have education coordination, like a coordination specialist with a focus on a thematic area. Maybe this gives the drive to the global coordination unit to focus on those ISAC mandated cross-cutting issues.
Can I also
all sectors?
Just say that the information from UNICEF, shout out to Patricia and Vanya on our education side, because that's not from me.
Yeah.
Thank you. So I don't know very much about education, but it's great to hear this is being done during emergencies. But one of the big things we've learned about health is the opportunity we have for health, strengthening health systems in the long term after an emergency. And I just wonder if, we know that the best thing you can do for a child's long-term mental health and into adulthood is to be in good education for life or throughout their education period. So what have you been able to do to strengthen education systems in countries where you're working to make sure that children are likely to have a better education, apart from the specific interventions for MHPSS?
So one of the core functions I mentioned is monitoring, evaluation, and strategy implementation. We cannot have a framework without SOPs, standards in place. So these standards ensure reaching the quality. Nothing is perfect and fully great. We cannot do it alone. We can ensure having SOPs, guidelines attached or linked to our strategy. I have the same question in the implementation of the strategy. Is it still on papers because we like to see it integrated? How it is working really on the ground, and that's how we can see maybe if we reach this quality gradually or from the moment we start the intervention. So we count on intersectoral coordination with other sectors because we can't do it alone. So we need health as much as we need the MHPSS technical working group, as much as we need other AoRs and CP AoR as well. So
I just wanted to comment that it resonates to me, and then it's a kind of also reflection when you mention about the language, somehow harmonization, PSS, social emotional learning, mental health in schools, mental health and psychosocial support in education. I wonder, it really resonates to me because if there is not a unified language, but a unified vision of what that actually means in the education system as such, as a platform. And I say this and I really kind of gets my attention as I don't know, in our field as MHPSS reference group, trying to build the bridge with immerses in education that we had a few years ago. And it's when we were quite in touch, and we recognized that there were groups, literally different groups far from each other. No? So I think it's more than language. I wonder what are the actions that could be taking place, because I'm feeling more and more interested as a platform of a social ecological transformation. It's where community-based activities happens. It's the core of a community because they are the caregivers, the parents, not only the children, and so on and so forth.
Can you answer that in 30 seconds?
Yeah. So the first action we took, we worked on the EIE MHPSS in coordination learning module to ensure coordinators have this knowledge and terminologies. We need to be flexible at country level, all. If it is working for them, regardless the term, that means the service is being delivered in a good quality way. So sometimes, because we talk about localization, we don't focus about the terminologies on country level, and we don't have a supervision police role when we support countries. If it's working for them, we try to show the other maybe best way. If it doesn't work, it doesn't work. And we said, we talked about decolonization. Same should happen for SEL, for social emotional learning. Same. In any country we are, in any context we are working. Hope is hope. Social emotional learning skills are the same set of skills. What they want to call it, it depends on the framework in the country and what is the, maybe, the system knows it. We had a discussion, sorry, this is really one second, about yoga, half an hour. They don't know what is yoga. Why we should introduce in emergency something new that the children not used to implement a guidance, and we say we contextualize it only by translating it. They do meditation in different ways. Children used to pray maybe scream, shout, I don't know. So let's start with build on what the community has and what our children used to, rather than bringing.
Introducing new things that will take time also to understand. Thank you very much, Ella, for your interventions. Thank you. Yeah. And now we will quickly move to health. I don't know if you guys want to stand up and stretch while he's doing that, but Fami can just, no, we didn't say to go outside. Just stand where you are and then sit back down as Fami takes us through health. Fami, over to you.
Hi, everyone. So I'm coming from a different session. Sylvie didn't take me for the surge deployment, so I'm back to health again. No, to be fair to health sector update on MHPSS during the last year, I don't think it's even possible to list the strategic updates in the 5 minutes allocated to this part, because a lot has happened in the health sector. And as we say in the minimum service package and in our handbook for MHPSS coordination, mental health and psychosocial support is cross-cutting across sectors and within sectors. So to be fair to health, I need to talk about what's happening in health in general, but also what happened in infectious disease, what happened in reproductive health, what happened in violence management, what happened in non-communicable disease, what happened in tropical disease and neglected tropical disease, and pediatrics, and the list go on. So it's impossible to do so in 5 minutes. So we selected few topics, and I'm doing that on behalf of Mark van Omeren, who for health condition couldn't be here with us. So I'm doing this on behalf of him and partners and various colleagues sitting here who work on the health sector. So key strategic important things. The IHK, the Interagency Health Kit, the mental health kit, and the update in the EML, essential medication list. There is a Lancet publication. We haven't shared in the newsletter. We will include in the newsletter that explains the rationale for the update of the essential medication list of the World Health Organization and why we added the largest number of medication and make the biggest amount of changes. So it's not only adding medicine, and why we add medicine? Because there are new medicine in the world. And with the new medicine come new evidence. And MHGAP guidelines, not MHGAP guide, was actually updated and released. So the recommendation we have for the world, as a World Health Organization within MHGAP, which say which treatment to use for depression, which treatment to use for psychosis, which treatment now for anxiety, for which Brandon is the focal point, for example. And now we have an anxiety module in the new MHGAP, and we'll have an anxiety recommendation, very relevant for our work in emergencies that we didn't have before. All that have now new recommendation will have new medication, including updating pre-existing medication, and that's why the email has to be updated. Surprisingly, some of the medications that were included in emergencies are now removed from the email, such as chloropromazine injection, now obsolete, because there are alternatives which are of same price and have less side effects. So some medication were added, some medication were modified, and some medication were actually removed. For us, historically, in the health sector, that's the biggest email update, which is associated with the MHGAP update. MHGAP intervention guide, which is a clinical algorithm, is not yet updated. It's an updating process. MHGAP recommendations, which is the science on which medication and which treatment to use, is the one which is updated. And since that get updated, the medication which get procured in emergencies need to get updated. And the Interagency Health Kit, as the name shows, is not owned by the World Health Organization. The process is facilitated by WHO, but the approval of medication in the Interagency Health Kit, which represent any procurement done for medication in emergency, has to be approved by, fully approved for any change to happen. ICRC, IFRC, UNHCR, MSF, and UNICEF, and the World Health Organization. And it gets updated every 5 years. And the time for its update was last year and published 2024. And you cannot change the IHK in between. And you cannot change it as a single agency. So agencies can veto, and that's what happened. World Health Organization proposed, I see Peter hiding, has proposed that, no, we agree. At the end, we have to agree. Why we have to agree? Simply because this is a procurement that go to the big trucks that would cross the border in acute humanitarian emergency. Any change will affect the price and will affect the size of the package. Means there is less food, there is less items which get introduced. That's why we all has to agree together if any change has happened. So this IHK is for 10,000 people, not for 10,000 patients, for 10,000 catchment area, for 10,000 people for 3 months. And the IHK does not include mental health medication. The additional supplementary kit include mental health medication. The IHK main kit includes things like bandages, like fluids, like something for rehydration. And any change really affects the price and size. So supplementary kit is different, got for 1,000 people for 3 months. Again, not patients, 1,000 people, catchment area based on the estimate of need. Yes, there is difference between both, Sarah. Means the dose that a patient would need is not the same. The estimate for the needs in armed conflicts are not the same for various mental health conditions, the non-armed conflicts, for example. So the estimates and calculation are based on the EPI. So that's something general we can use for everyone. But it covers 1,000 catchment area, meaning that if you're going to cover a city that have 10,000 people, then you need to make sure you get 1,000 kit times 10. This is actually how the kit look like. There is an actual kit, and it is the same. So you open, there are the various medication, you know that this covers 1,000 people for 3 months. It has one antipsychotic, one antidepressant, one anticholinergic medication, one anti-epileptic medication, and one anxiolytic, and one medication to manage naloxone, which manage opiate toxicity, which is life-saving. The main change we made was actually making the anticholinergic medication, which deal with the side effect of antipsychotic medication, injection rather than pill. And we managed to keep everything else. And keeping things is also an achievement, because usually agencies request decreasing in amount of medication to reduce costs. So we kept what we have, we added one medication, and we wanted to change the dosing of some medication, what was approved by a group of pharmacists. You have to defend the case of keeping the medication or changing in front of group of pharmacists. So we have to go to something like a court, which is a court full of pharmacists, and defend the case of this medication. So we managed to add a pill cutter, which was not in our kit. So we put cutter, injection of anticholinergic medication. Yeah, we have to defend the case and reach consensus. What Peter in UNHCR and colleagues in MSF did not agree to change was the clozapine. And they have a rationale for that, because the laboratory tests required for this medication are not available in many humanitarian organizations and in many humanitarian emergencies.
And I get to do this to Fami too, 2 minutes.
Okay. I move to the mental health kit. Mental health kit is different from the IHK. If we use this for rapid procurement, then we use the mental health kit for procurement in humanitarian hub. And IHK, while it's for acute emergency, the mental health kit by WHO, which is available online, all that you can Google online and find what is the IHK, what is the mental health kit, and how to procure. The mental health kit is what we keep in humanitarian hubs, such as in Dubai humanitarian hub, for example, for rapid procurement, pre-bought, so you fast-track procurement. And that would include medications such as clozapine, and advice on the lab tests, and other medication beyond the 5 medication only of IHK. That's what happened in protracted crisis, when an agency take over the whole procurement for health system, like what happened in Yemen, for example, what happened in Syria. So that's the different. IHK is what would go acutely to Gaza immediately after an emergency, or Tigray, the whole health system got affected. But mental health kit is for pre-procurement. Let's move to the next. I cannot cover all the capacity building initiatives, but I'm putting one here, which is the Open WHO course, available for free, online, self-paced, 8 hours, where you get orientation for health sector, your responders on what mental health and psychosocial support is. Another great initiative happening between International Medical Corps and the World Health Organization. We see growth in multi-sectoral approaches in Francophone Help Desk for Technical Working Group, but for sector-specific interventions such as MHGAP, HIG, we also don't have enough specialists in most places in Africa, in Francophone Africa. So there was a capacity building course that was done by the two organizations, MHGAP Humanitarian Intervention Guide, totally in French, with a follow-up for programming that was run for many weeks after on integration of mental health into primary health care and general health care setting based on MHGAP operations manual and the IMC integration toolkit. I think one of the key achievements for the health sector this year was actually the mental health and psychosocial support resolution, which actually emphasized that MHPSS is multi-sectoral. And MHPSS is MHPSS, not only mental health. And MHPSS tools by the IASC reference group should be used by the health sector, and that the collaboration need to happen with other sectors. I'll stop here, Terry, and happy. Simona want to ask question. I think we take question from Simona, then back to Terry.
So my question is a bit general, but specific to psychotropic medication, and it's general regarding MHGAP in general. So I'm asking about reflections done, especially that many organizations, and I guess WHO is monitoring the implementation of MHGAP in multiple countries, and we're facing lots of challenges. And it also goes back to the question of rational use of drugs, the same behavior that we have for antibiotics and now for psychotropics, etc. So where are we in terms of addressing these challenges, where the reflection in general for GPs, PHCCs, rational use of drugs and changing behavior regarding the psychotropic medication?
Great question, Simona. There is a misconception about MHGAP, that MHGAP is about medication. That's a misconception. And to change this misconception, you simply need to open any module in MHGAP. And if you open any module in MHGAP, there is no single module that do not start with psychosocial interventions. And even the clear recommendation that you start in most of conditions with psychosocial intervention. But there is no single module where MHGAP would tell you, use medication at primary health care. That does not exist. That's a misconception. So we need to use MHGAP to be able to correct the rational use of medication. And remember, tools such as interpersonal therapy or tools such as PM+, or among all these tools are actually part of the MHGAP package. MHGAP is the name of a program. The MHGAP intervention guide is the name of the algorithm. But psychological intervention are also part of MHGAP and has the MHGAP logo. And MHGAP intervention guide, which is for primary health care, does not only include medication, include also psychosocial intervention.
Thank you, Fahmi. Okay, GBV ready? Monica, sorry. Sorry. You can start speaking from there.
So yes, I'm Monica. I work from, but like many of you, I have like multiple hats. So among those hats, I have the hat of co-chairing the MHPSS task team under the GBV AoR. So this is what I'm going to talk about now. Basically, in terms of like this MHPSS task team, we have different core members of the GBV AoR, and I'm going to list some of the initiatives of things we've been doing in trying to strengthen and integrate MHPSS into GBV, and also acknowledging and picking Peter's words, in GBV there's a lot already happening in terms of MHPSS. So among these things, we did an MSP workshop for MHPSS task team members. We did a webinar in collaboration with Cécile on GBV and MHPSS in French. We'd also, because we had this group of core members, we managed to engage and cross-reference in terms of other advisory groups of GBV AoR and things happening in terms of GBV and MHPSS, as for instance, the guideline UNFPA is developing interagency on integrating or strengthening GBV and SRH in MHPSS. So we had people from the MHPSS team. Or also, for instance, we had the GBV case management guidelines, and we managed to also had there were some sessions, some mentoring sessions of GBV case workers across the globe, like a lot of people. And there, for instance, we had one of self-care and then one on MHPSS, MSP, and trauma-informed care. And I want to bring that word in a moment. And then also we've been also having within the GBV AOR a person providing capacity building on self-care for GBV providers. And I think that it was very important also because we were linking a bit like these MHPSS competencies we talk about, like self-awareness, etc., together with self-care. And this is a work that is being done across the globe by one of the co-chairs. Actually, I'm one of the co-chairs, but there's Yihan, that is not obviously here, from Trocaire, and Paula. So I want to mention them also because this work has been collaborative. And then we've been, and this is something we need to follow up, facilitating at least one session with MHPSS reference group members and the MHPSS test team. So this was a session that needs to follow up. And we were like sort of laying the ground to discuss certain topics about MHPSS, no? That always is. And I think that I was kind of happy to hear our colleague from education when you said like there's a lot to do in terms of the language, no? And I think that sometimes it's more about language rather than real barriers, or it's more about MHPSS people or people that we work in MHPSS knowing about what is the programming and finding a lot of like coincidences and points to work together. So that was a bit of like the first start of that. How can we improve? Because this was what we've been doing. I think that is vice versa, so engaging more in the reference group. We have multiple hats, so sometimes it's difficult, but engaging more in the MHPSS reference group and trying to show and bring the GBV core work within the MHPSS reference groups and vice versa. I think that MHPSS reference group also approaching GBV actors and trying to understand what they're doing and trying to understand also the multiple entry points that we have in both areas of work, MHPSS in other sectors, I mean. Another thing that I think is important is, well, no, I think that is that, like, and sharing initiatives in general. And then in terms of support, one of the supports is like the MHPSS task team, like the MHPSS co-chairs continuing engaging, because Carmen was actually part of the MHPSS task team, so having that engagement, continuing engagement, and then engaging in conversations, and I've been thinking about one of them, like following up on this and maybe having guidance, I don't know, which we know a lot about language that we know that in the MHPSS world is kind of banned or like very like this sticky point, like trauma, and that in GBV we use trauma-informed care, and I think that this is something that is a bit of an elephant in the room sometimes, because I understand perfectly, and I'm a clinical psychologist, I understand why no, we cannot talk about trauma and what are those consequences, but I think that this sometimes create barriers when working with GBV, and I think that this, for instance, is something that we should talk and try to bridge that bridge, because I think that is really important. And so this is basically my point. I was very brief.
Thank you, Monica. Thank you very much. Can we take questions after lunch, maybe? Or we can just have the discussions during the lunch hour, kindly, colleagues, so that we can hear from Child Protection, the recorded version by Kun. Okay. All right. Can we hold on to the questions, or should we take questions? Because there's a bit of hands up. Okay, let's take a bit of questions and reflections, please.
I just wanted to mention briefly, as many of you know, there's been a global project on strengthening MHPSS services for GBV survivors. And the first phase of that project was led by the George Washington University Global Women's Institute with Trocaira, and it's now in a second phase, 2-year project for further refining the guidance and capacity building in humanitarian settings, and International Medical Corps is a part of this project. Now we were invited both for GBV and MHPSS expertise. We want to just remind everyone of the guidance that had been produced before, but also to update everyone that we will be working on really further refining through the piloting in Ethiopia and Somalia. And we're also revisiting the advisory board, not only for those who were on the advisory board previously and looking to re-engage, and I really hope to connect with you, but also for those of you who may have not been involved before but would like to be. We'd just like to make a plug. Please feel free to reach out to any of us, and we'd be most happy to discuss. And of course, we'll share updates as we have them. Thank you.
I think we can proceed for lunch. Lunch is scheduled for 1 hour, but we do CP.
We come back at 1:45.
Exactly. So instead of 1 hour, we take 45 minutes kindly, so that we continue with the next sessions. No, we are going for lunch for 45 minutes, and we shall reconvene after 45 minutes. So 1:45.
We weren't allowed to hang the things up on the walls, so we have to use the whiteboard. We'll keep it up for the rest of the day. People can kind of fill it out as we go. Thank you.
What they said about
This one's working.
Do you like to watch a video by Kun? Right? It's very important. He is not frozen in time, but he sent us a very nice video about CPAOR activities. Let's see the video by Kun.
Dear colleagues, dear friends, hello. It's with great regret that I am sending you this video. Of course, I would like to be there, see you all, have some interesting discussions and have some laughs as well. The reason why I'm not with you is because the funding for the work that I do with the child protection area of responsibility has been drying up. So there was no more money for non-deployment travel, and actually there was in a couple of months no more money for my role at all. I will still continue for a couple of months half-time, And then, as it is now, this position will stop. As you know, my position is co-finance between Save the Children and UNICEF, and it's the UNICEF side that where there is no more money. But anyhow, some updates from the CPAOR over the last year. We have been supporting countries. That's where the last year the accent was, the stress was, and we have been working with 38 countries. We're very happy that they all produced an HRP, an HNO and an HRP, which is one of our main jobs, of course. What was different the last year compared to the years before is that we put much more stress on community-owned development and humanitarian work on one hand. And also on the other hand, we've been really looking at how many people that we are reaching in comparison, and that's important, to the number of people that are actually in need. And we're not doing that great, I must say. And the solution for that would obviously be working closer with the health sector, with the education sector, with the nutrition sector, so that child protection can really focus on what they're supposed to do, which is the social work and the case management, supporting small groups and one-to-one support. Yes, there are some things that I want to ask the help of the reference group for in the next year. And that is really increasing our critical look at the meaningfulness of certain interventions that we are promoting. And when I talk about meaningfulness, I talk about three aspects. The first thing, again, is the coverage. I think we really need to question which interventions that we promote, because there are some interventions which are on layer 2, so based for the community and families and so, but we really reach so few of the population in need with that. On the other hand, I think we should also look at the significance of some interventions, because there are interventions like parenting, education, PFA, and these names sound good, but how they are done in practice, sometimes we see that's a bit challenging. Just visiting one house and then counting them as beneficiaries to meet the targets set out in proposals for donors, and the humanitarian response plan is not really a meaningful intervention. I think we should try to stop those things, because they're not significant and they do not really improve the mental health and psychosocial well-being of people. And then the third aspect of meaningfulness, I think it's also the community ownership of the work that we do. I think we need to work more with faith-based institutions, groups. We need to work more with traditional healers. And the answer to this is not that we have guidance. I know we have guidance, but we need to do much more. I think they need to be included, for example, in 4Ws, also in the guidance of 4Ws. And actually, all the non-humanitarian actors in the field need to be included in the 4Ws. So also football clubs, dance clubs, and etc. So that is all for my part. At the same time, also a call if you are an agency that want to contribute to the greater good and has funding for a standby partner in this child protection area of responsibility, then let us know. We're happy to cooperate. Thank you very much and enjoy being together. Success with the meeting.
I wish Koen was here to get this feedback, but please, if you have questions and have follow-up, please send to him. Koen is very accessible and good colleague and friend to many of us. I think he gave good insights, and a message to me as well. When many years ago, and I was co-chairing the group with Sarah Harrison, we were also doing more joint missions with the child protection AOR. I think they were very useful for the field. Going with another area of responsibility, I think we should do more of that, also including GBVOR and education. I wish to travel one time, and also Terry, I'm sure, with education, with GBV colleague. I think they're really useful when we go as two coordination mechanism to the field. So that's a key message I'm taking from Kun Wise and good video, and he look wise also. I like how he look in the video. So indeed it's wise content and attitude as well. Ala, please.
You mentioned the joint missions, and hopefully there is an opportunity.
Where?
Now, I've learned yesterday that Lebanon will be implementing the MSP through the MHPSS technical force, and for the first time we see the collaboration between the sectors and the technical working group. And I will be deployed starting 1st of December.
Very good.
To support the education sector.
And good luck.
So
courage.
we welcome the reference group deployment to the country.
With pleasure. No, there are discussions. Also, there might be, as you know, I speak Arabic, and there might be a deployment to Lebanon. But I want it not to be a very short, so I'm useful with the colleague. However, you may not need us as co-chair because we have Rita as a technical working group also deployed through Surge. So until there is a request that, I don't have a request now, but I have thinking that there might be a mission. But I think use our Surge deployed colleague Rita, who is very strong as a representative on our behalf, and through Rita, we share this with the education until one of the co-chairs get deployed, and there is a clear request. But
at least to bless these efforts from the beginning, because we rarely see it.
Yeah.
And to show that even with disagreement between sectors, that no PSS, recreational activities, CP will lead, education shouldn't do this. So there is a fight, and obviously for funding, maybe they can see it that from the global level, country level, we coordinate together. We know.
Happy to do that. So we have a current surge in Lebanon. We support you either through potential deployment or remotely. I think Lebanon can be a good example because also multiple sectors are engaged in co-sharing. So it's UNICEF, it's IMC, and WHO together with the government are co-chairing the group. We have a surge deployed there. We have a potential request for deployments from the reference group, and we have almost many of the agencies here around the room who are active in Lebanon. So I'm so happy that education will work there, and let's not only focus on this one example, which is a clear one we can do quickly, but I think of other opportunities, other sectors and cluster for joint multi-sectoral deployments so that we approach the country together as a group. But Lebanon, let's initiate a discussion about it. Thank you. Can we move to breaking the silo, which is a nice match with what we are discussing. Okay, colleagues, we felt when we were developing the agenda that every time we discuss about sectors and clusters, we have updates from CPR, have updates from GBV, have updates from education, from protection and health. But the humanitarian field are not only this group of clusters and sectors. And since the IASC guidelines and the minimum service package, we always talk about multi-sectoral approach, but there are sectors we barely approach. We almost have no activities with them. So we thought, can we talk about sectors and cluster we almost have no activities about? We theoretically have representation, but in reality, we don't have any updates. And brainstorming groups around the tables now, how can we do better in engaging with those sectors? Because there are so many good opportunities. The question to answer is, in groups, in your table, in the next 10 to 15 minutes, give us tasks for the work plan. The work plan that will start from September next year. Give us tasks in the work plan. What are some recommended concrete steps that the IASC MHPSS reference group can do to engage water, sanitation and hygiene, nutrition, food security, shelter, mine action, and other sectors we are currently engaged with less frequently? Some of you might be working with those. Great opportunity. Say that in your group and say, If I am Terdizom working with this, if I'm IASC working with this sector, I am willing to strengthen the collaboration and apply MSP and other ISC tools. So please volunteer to give us updates from these sectors in the coming months, in reference group regular meetings, and in the next annual meeting. Tell us what you want to do, what capacity building, what interaction. Do any agency want to volunteer to do more? This is a question. But some of you may say, who are the agencies leading this cluster? We know who is the health cluster lead. We know who is education cluster lead. Who are leading these clusters that we interact with the least? Shelter. It's I4C and UNHCR. I4C deal with natural emergencies and UNHCR when it comes to shelter. UNHCR deal with armed conflicts in relation to shelter. There are some initiatives when it comes to shelter. So Carmen has led on the development of a very nice guidance, which is near completion, not published yet. But it's beyond guidance. We want to do with shelter as we do with health and protection education so that we are multi-sector. There's a lot that can be done, which is currently not done. Nutrition, UNICEF. WASH, UNICEF. Food security, FAO and WFP. We don't have the representative here. We want to interact with them more. Mine Action, UNMAS. We have no representative from Mine Action. But again, I4C has conducted some interaction, good interaction with Mine Action. But we need to do more. That's not enough. In groups, discuss and give us concrete action. And any volunteer agencies, please volunteer. And please write that, because we'll not be able to get feedback from everyone, but we will take the written feedback and integrate into our work plan. And we'll take a sample from the room. You have 15 minutes for this exercise. You and me should have jobs.
Do you also feel it's a bit warm here? Yeah, it gets settled down.
I'm getting my shoulder.
Yeah.
Colleagues, we have 2 minutes to wrap up the discussion. We'll hear reflections from IOM, World Vision, and Americas. And then UNICEF at the end.
Okay, so we start there.
With Amal.
Yeah.
Amal, can we get your insights, please, the insights of your table on the interaction with this sector? I would kindly ask you in maximum 2 minutes, give us this reflection. But before talking about the sectors, clusters, and AOR, can you please tell us about your new role on IOM? What are you doing in Geneva with IOM?
Hello, everyone. So my name is Amal Ataya. I'm the Senior Roving MHPSS Officer. My new role, I just joined a few weeks ago. So I'll be supporting the different emergencies, different field missions. So I'm responsible for the humanitarian portfolio in terms of MHPSS. And yeah, usually I've been in the field, I've been in IOM for like 16 years, working in different emergencies, either emergency setting or post-emergency settings, working on capacity building programs and direct intervention and supporting coordination working groups as well. So yeah, part of the new role, I think will be also supporting the different thematic working groups as well, in addition to technical support to field missions. Okay, back to the exercise. So mainly we started with the discussion on different agencies, like what type of interventions we have with the different sectors. So from PUI, there's some work on integrating MHPSS and in nutrition and health. So some examples were like mother and baby centers within health centers, focusing on malnutrition, child development, mother's well-being, as well as topics related to WASH as well. And IRC also, the focus was on nutrition and WASH, mainly the engagement. We were discussing to outreach to clusters to provide maybe trainings on MHPSS considerations in their interventions, and also to invite the clusters to our conversations. So maybe we can do a survey and then engage them in discussions on the main challenges and identify focal points from the clusters so that we can engage. And then also we gave some examples on mine action, that it can be an avenue to work on MHPSS and peace building in addition to the work they do and the referrals to health as well. Also, we gave some examples about, for example, IOM, we work closely with shelter teams and site planners to ensure that we have child-friendly spaces, women and girl spaces, and also the design of the shelters and the site to make sure that the community can socialize and can have community centers or spaces to engage. I think I covered all.
Can I ask you to educate me on a certain point, please?
Yes.
I'm never able to understand the complexity of difference between shelter and CCM.
Okay. I can give an example because this is something I was involved in. For example, as IOM, we're the co-lead on the camp management and camp coordination.
Exactly.
And then, for example, the shelter can be like, for example, in Haiti, the camp closure, once they're closing the camps, then there's a transitional shelters. The population, like the IDPs, are moved to transitional shelter. And this is where our interventions as MHPSS to include MHPSS consideration in the site planning and the transitional shelter. So I think like now it's shelter and FI usually the cluster, but I think CCM is like directly in the emergency when the camps are established, and then there's a different cycle until the camp closure, and usually after that there's the transition to transition.
I'm asking because I think we might be a bit more advanced with CCM integration rather than shelter integration. We have guidance, which I think now 8-9 years. With the CCMs that the IASC MHPSS reference group has established, but the guidance on shelter are still in finalization process. And I think likely there might be lessons learned from CCM integration that can be applied and applicable to shelter. So I think we can do more with shelter, noting that we have leadership on technical inputs on this area. Welcome to your new role in Geneva, and we all look forward to working with you, Amal. Let's give the mic, please, to Americas. And please, Glenn, give us an overview. What did your table discuss?
Yeah, a lot of you may not know of us. We've been around for 40 years, but mainly in the medicine security space. We give away about $1 billion of donated medicines a year. And so it's a large part of what we do. But we've always done health system strengthening. And about probably 7 years ago, we added WASH, MHPSS, healthcare work with NCDs and MHPSS, asthma, MHPSS, climate now, infection prevention and control, climate and disaster resilience is a new office for us, and safe and accountable programming or protection. Yeah, and we're involved in MHPSS work in about 20 countries, and disasters and areas of armed conflict. Armed conflict is new for us, so we're in Ukraine and Gaza. We've almost completely localized our approach by giving grants to smaller NGOs and providing technical support and staff care and that kind of thing. Okay, so our group spoke of, someone said to have the authority to speak on behalf of the MHPSS reference group. For example, MHPSS in a shelter meeting. Interesting discussion about small INGOs. They're very, the staff are very involved in the field. It's difficult to represent a lot of, groups and committees, and there is a bias against the smaller NGOs to advocate. One group has 5 technical advisors. We probably have about the same, 6. And time is dedicated already to a lot of groups and areas, all not funded. Salaries are often project-oriented and not the overall funding. Country and regional staff cannot cover everything, need to rationalize what to attend, cannot be in all of the clusters and subgroups, need to know when the scheduled meetings are and have preliminary connections, need inclusion on agendas. MHPSS integrates in everything, making it harder to make connections, but the awareness is needed. Someone said to invite them into our meetings rather than think we've already have a clear MHPSS agenda. I think that's about it. There's no fundamental overall rejection of MHPSS anywhere, so people know of the need for inclusion. For example, in IPC knows the need, and they scheduled a discussion with MHPSS at one point. Where there is a thematic group like DRR, we knew we had to reach out to other sectors. Thanks.
Excellent. Thank you, Glenn, and welcome again. We missed, I think, America's previous meeting, if I'm correct, but this is the 3rd year where America is with us, and welcome to the reference group. Great to have you. Colleagues, I feel we always say protection and health are co-chairing most of the groups. The solution for that, I think, is not only to ask them to do less or not to ask them to do less, but actually to ask other sectors and clusters to do more that we have in the guidelines, and we barely approach them in day-to-day work, because actually protection and health are not always the most well-funded. Some of the clusters we talk about in many emergencies, they are the number one most well-funded. It's not usually protection and health or education. But that does not mean all other clusters should do less, but all these should do more to create the balance. Let's listen to World Vision. Fiona, please.
So World Vision works in over 100 countries. That includes our support offices countries in US, Netherlands, Germany, and others. We are known for health and nutrition, protection, education, food security, and livelihoods. So for mental health is a cross-cutting theme. And we have 30 structured MHPSS programming in 30 countries, and we hope to boost that up to 70. World Vision has a history of staying in a country for more than 15 years. So because we lead the development work, which sustains most of our work, and in most of the humanitarian crises, we have sustained humanitarian responses. So from the group here, we have Mine Action. DCA has existing engagement with the AoR and related advocacy channel. They are willing to discuss, and Sarah is available for further discussion and linkages.
Yeah.
And then for nutrition, and World Vision has a classic example with Food for the Hungry. We adopted PM Plus and Nurturing Care Group model. Yes. And it was pilot tested in Uganda and Guatemala. Wow. And the resource is available. We have permission from WHO to adapt the PM Plus for nutrition. Nurturing Care Group is a model they use in nutrition, which maybe most of you already know. So the model is available if you want to pilot test it or use it. We also have another example from World Vision, food security and livelihood in Iraq. We have a 5 years research study that Richard Bryan and Kate are helping from the University of New South Wales, where we are adapting PM Plus as a universal intervention to be delivered in a usual livelihood program. And our outcomes are to what extent that a mental health component enhance livelihood components and vice versa. The results so far are looking good. What is unique is the booster sessions that we do every year to sustain the learnings and enhance psychosocial well-being. We also have another example, just recent work with World Bank by World Vision and UNHCR in Nairobi that targeted host refugees, and it was targeting youth between 18 to 35 to increase their employability. It was a consortium of many other organizations, including IASC. The results are available as well to how the PM Plus really enhance youth employability. Another one, final, is WASH. So World Vision has psychological informed environments that basically are taught within a WASH program. That basically it's a PFA type, reaction to stress, coping mechanism, and referral. The good thing is it can be delivered by WASH colleagues, not necessarily MHPSS, specialists. Thank you.
Inspiring work by World Vision. I think I would like also to give the mic to ACF, to Guillaume, please, because we cannot talk about nutrition and MHPSS without an intervention from ACF, noting your well-known and long-standing manual on this integration. Give us some insight, quick tips in a minute, please, Guillaume, about MHPSS work and nutrition by ACF and where to look for, and if you have resources within your agency.
Yes, thank you. So we work on nutrition since an MHPSS, not MHPSS, at the beginning it was MHCP, Mental Health and Care Practices, under the nutrition security policy. And so we started in 2003-4, something like that. So it's a long history within our organization. And we have developed a lot of different protocols of care practices within a nutrition center for the different level of under nutrition status, etc. So we have manualized our protocol. So we have one very well-known on MHCP, mental health care practices within nutrition. We have revised this manual in 2020, and we expect to review this manual next year, integrating the new WHO guidelines on severe acute malnutrition, etc. So we are also a member of the nutrition cluster and the food security cluster.
You attend both?
No, not me, but my
ACF.
colleague. So we organize through different sectors within ACF France, and the other head of unit on nutrition, food sector, etc., are member of the nutrition sector or food security sector. So they know what we are doing in MHPSS.
Guillaume, can we make sure next year, in 2025, when we meet like in this meeting, can we make sure that ACF, among other agencies, give us update what happened in nutrition and food security clusters on MHPSS? Would you mind? And apologize for putting you on the spot, but you are ACF.
This is what we discussed in our group.
Amazing.
Yeah, I can make this. Yeah, we can.
This is exactly
But
like
not
asking
the
WHO to give updates on health. Exactly like that.
Okay. No. Yeah. Okay. It's a trap.
No, it's a recognition. We appreciate the work ACF is doing, and we're keen to hear more from your colleagues. And I think it's very important that we work all of us more. And we appreciate the leadership of ACF in that domain for years. For years, your work is among the world best, including the guidance, which I use many times as a reference when I want to talk about this topic.
Thank you, Femi.
Thank you, Guillaume, and I apologize, my friend, for putting you on the spot. UNICEF is a lead of two clusters mentioned. Zainab, what are you doing? What do you plan to do for these two important clusters on MHPSS?
I had no idea I was going to be asked this question, nor did I consult my nutrition and WASH colleagues, so please take this with a grain of salt. It's going to build a lot on what this group discussed. But I think, indeed, UNICEF does have a leadership role in these two spaces, and I do think that I feel like it's so loud. I feel like it is untapped. I think there's a lot of bridges that we can build, certainly. But I think we shouldn't forget that there are existing intersection points. And a lot of us, including in UNICEF, our ECD, for example, previously existed under nutrition. Now it exists under health. When it did exist under nutrition, we saw actually that the linkages with nutrition programs was clear. Amal, you spoke a little bit about, mother-baby groups and the importance of psychosocial conversations as part of infant stimulation. So there are certainly good practices that are happening, as well as, for example, through early childhood development specifically, and how it links with health and how it links with psychosocial support and nutrition sessions and whatnot. At the same time, the IASC guidelines, we already do have action sheets on how we integrate with these sectors, so we shouldn't be looking at setting up new activities or new guidance on what needs to be done, how we engage them. We don't want, WASH or nutrition actors to be MHPSS specialists. We already know, but what we do need is to better define and this is what we discussed in the group, is to define what does bridging actually look like with these sectors? Yeah. Are we strengthening things that are already happening on the ground from a programming perspective? Are we looking at better access? Are we looking at better mental health outcomes? Let us define that clearly so that we can start to bridge better. And operationally, as a reference group, how do we take that forward? Yeah. Perhaps we could actually develop a working group that is meant to really talk through, and this was Brandon's idea, not necessarily, not necessarily coming to it with a clear deliverable, but really have these, intentional conversations, consult with the clusters at both global level and country level to better understand what something that could be developed, what it would look like, what it would aim to do, and how it links with the MISP and how it links with the IASC guidelines. Not very helpful, Fahmi. I'm sorry.
Very helpful. I think what's important is that we discuss this topic. We have neglected emergencies, forgotten emergencies. I think we have forgotten sectors as well. And it's part of the reasons why we are less multi-sectoral, because all these sectors, they are not all sectors which are slightly forgotten or less prioritized, but there are many. I like the idea of a group, but I like also the idea of concrete deliverables a group can brainstorm on. Sarah wants to say something. Thank you, Zainab.
Thank you. It's just to say that back in the day, if I can say that, in the reference group, we used to have this kind of concept of burden sharing, to put it frankly, and that if your agency had a specialism, I don't know, in food security and was also doing MHPSS programming, it was your role to take on the responsibility of linking.
Exactly.
It doesn't have to be one agency, it could be 3 agencies working on food security. And we seem to have lost that over the past few years because it's, I can say from my FIC perspective, a lot of it just sat on the co-chair position, and it's not fair on the co-chair, whoever's in that role, because it's too big for one person. So I think we really need to get back to this concept of collective ownership, collective burden sharing. And if your agency has the specialism, then it's not you that has to go to the mine action cluster, but you might have a colleague that does. So it's you linking up with your colleague and say, can you give me the top 5 points that this cluster worked on last year or is thinking about? And this is where we need to engage on MHPSS. So it's not the additional work for you as an agency member is your internal conversation with your other technical counterpart that might be attending it. Because if it stays with the co-chairs, it's just going to be unsustainable. And it's not a fair workload on them, and they're not also necessarily specialists in all of those areas, so they're not the right advocates. But some of your agencies are, and I think some agencies that used to do that, some of them aren't here this year, for example, but it might also be that reactivating that concept of collective burden sharing and ownership that we used to have.
Okay. Thank you, Sarah. Great point. We hear Zainab and then Mohammed.
Just a really quick point, and I was thinking, we were discussing in the group, Annie, I mean, the livelihoods, the cash transfer and livelihoods working group, I think there's so much to learn from your work and what you're doing, which has honestly been so extensive in helping to build that bridge. So maybe not to put you on the spot right now, but I really think there's a lot to learn because I'm part of that working group, and it's a lot that you're taking on to just really define what it is that we can do on the ground and how we can get the livelihoods folks on board with us. Even though in my mind, livelihoods is way easier than WASH, like in terms of practicalities.
Yeah. Thank you, Zainab. Mohammed, then I think we would conclude this part of this session with some suggested actions.
Yeah, I just want to follow up after Sarah, because what she mentioned, I would say is a good model of working, and I would mention a good practice we did in our team. So we work closely with people from like infection prevention and control, WASH, and we recently engaged with them. They were developing a guidance for home care for monkeypox, and we asked them to like review this guidance, and we reviewed it, and we ensured that MHPSS was considered in this guidance. So most of our organization do other things in addition to MHPSS. So talking to these people and understanding exactly what they are doing and how can we integrate MHPSS. So having more understanding of what they are doing will help us to imagine how MHPSS could be considered in the work.
Thank you, Mohammed. And I want to use the opportunity to invite you, introduce your organization, the work you do.
Yes. Yeah, so I work with the UK Public Health Support Team based at London School of Hygiene and Tropical Medicine and the UK Health Security Agency, and our work focus mainly on infectious outbreak response and preparedness. We work mainly in research, and also we have a deployment mechanism, but it's mainly, unfortunately, we didn't get a MHPSS request, mainly like epidemiology, social science, and infection prevention and control.
And you heard about the writing workshop, which we'll have in Addis Ababa in collaboration with ARC next year. He will be,
supporting that.
Thank you, Mohammed, and thank you, colleagues. It's not a voting, but I want to get a sense of the temperature in the room, because that's a little bit new thing or something we try to revive. Please raise your hand as a representative of agency only. I kindly ask observers not to raise their hand in this part. Would you please raise your Would you please raise your hand if you want to see this topic in the work plan starting from September 2025, the next work plan we will agree upon at this topic of. Okay, there is a majority, I think. Perfect. Thank you, colleagues. We will find ways of doing action. Thank you, colleagues. You can lower your hand. Very clear. This will be in our work plan, whether as a thematic group or whether as concrete activities of burden sharing, or whether as series of meeting as group to decide on actions required, but we find a way to include that in the next work plan. And it's for the coming co-chair, starting from September next year, also to find resources to do this work across the year, because I think it's critical. In the next 7 minutes, we'll try also to break silos. The International Criminal Court, funded by the Ministry of Foreign Affairs, have done excellent work on bridging with the justice system. Can you give us an orientation in the next 5 minutes to learn more about this new area we might need to bridge with?
Yes, thank you. And I promise I will be brief. Yes.
Thank you.
So thank you for giving me time. And again, thank you for inviting me in this group. And I'm very much a fan of building bridges, because I see already many links. Although we are not a humanitarian organization, I see the links with what we do. So just in a nutshell, I want to go back to the study which I very briefly talked about yesterday. So I did a study with the support of the Knowledge Management Fund and the Dutch Foreign Ministry, who funded the study. It was supported by the ICC, although it was independent from the ICC, and I did it in collaboration with Stanford University, just to kind of give an update. And basically the idea was to bring together the good practices that were developed over the past years around the integration of MHPSS in accountability mechanisms for atrocity crimes. That's a long title. And just to give a little bit of a background on the on where we stand on MHPS, on accountability mechanisms for atrocity crimes. Obviously, everybody thinks about trials and international courts, etc. But it's actually much larger. And you see, since we talked yesterday about peace building, I just kind of put up this figure where you see there is an overlap with what is done in transitional justice and peace building, but not everything applies. Basically, what we are looking at is all the processes, whether it's trials, whether it's investigative mechanisms, commissions of inquiry, documenting exercises, etc., where victims and witnesses are requested to tell their story, are requested to be interviewed, where what has happened to them is documented and then taken further to court or not, depending on the mechanism. So, but we are, of course, we are focused on this process of an investigative interview. So an interview, not a mental health assessment, but an interview to establish the facts, and a testimony in a context of justice or accountability. That's basically what we defined. And just to say, we focused on MHPSS, we focused on the definition of MHPSS like it is in the guidelines. Because we believe it's a very strong framework with the pyramid, etc. We adapted that to our needs. But to come back to the elephant in the room that was Monica brought up, we do focus a lot on trauma and trauma-informed care for the simple reason that it is very relevant for interviewing and bringing back memories. And so there is a focus on that, but we are very clear that for us, the approach is much broader than only the trauma-informed care, but it is there. Just to very quick, we focused on 4 areas where we believe that MHPSS can make a difference in these processes. And first of all, it is obviously MHPSS interventions can help to mitigate risk, to help to do no harm for victims, victims or witnesses. These involve also perpetrators. It can improve well-being also, obviously, but the well-being throughout the process and the well-being afterwards, and the way how people look back at their experience of being involved in a justice mechanism. It will also, and that is very important in my view, an MHPSS intervention can also help to enhance the quality of the evidence that is provided, to enhance the quality of interviewing, to enhance the quality of the end product, and in this way also enhance or strengthen the process as such. And last but not least, it obviously can also help by addressing vicarious trauma, which is a huge issue among investigators and people who are doing this work a long time, and other mental health risk for professionals. And by focusing on these 4 areas or these 4 goals, we see that we can, or we believe that the capacity of accountability mechanisms to be effective and to bring healing is improved or is enhanced, and we also in the long run facilitate access to justice for victims, because if victims see that they can trust the system, they feel they will not be re-victimized, etc., there will be more people coming forward, etc. We had a long consultation process, so there was partly a desk review, a literature review, and then there was a large consultation process to kind of capture the good practices, and those we kind of transformed into a set of actionable recommendations, and we structure them along the timeline of the involvement of victims and witnesses with the justice system, starting from the beginning of investigations, all the end to, if there is a trial, to the appeal stage and reparations, etc. Of course, a lot of these processes only focus on a little part, mostly on investigations, so organizations documenting crimes or people who are taking stories from refugees, etc., they would only focus on the beginning, but in total you can go through the whole timeline. So finally, and that's my last slide, I promise. So we did this research, it was very well received. The copies I brought are gone, I'm sorry, but I will put up the QR code. And there was a lot of interest, there is clearly a lot of momentum around this topic, and we want to take this forward. This is also why I'm so happy to be here with you these days and to be an observer in this group, because we not only want to further disseminate the findings of this study, that's also, now that I'm back at the ICC, also the role of the ICC to kind of promote this, the Rome Statute system. But also, of course, there is still a lot of room for improvement. This is just the beginning. So I'm also very much looking forward. If you have any feedback or comments, please contact me. We want to build a community of practice kind of loosely. We want to kind of make the group of people who are interested in this from the MHPSS side bigger and kind of make more connections. And most importantly, what is at hand now is that we are concretely looking at setting up a group and a call for action to develop international standards around this. I mean, there are a number of protocols which are very useful and guiding principles. We talked earlier about the Istanbul Protocol, etc. But I think there is space, or we think there is space for a set of standards, which whoever is involved in this work know that these are the things we need to take care of to not harm people, to make processes effective, etc. So we will, if you're interested would be interested in joining this group, I don't know how the composition will look like at the end. It will be a multidisciplinary group. It is very much linked also to legal work. Yes, let me know. And I hope that maybe next year I can come back and present you the outcome. Just to say as well, as a final word, we called it the Antigone Project as a working title, referring to the play of Sophocles, where Antigone is in fact refusing to stick to the rule of the court, and she goes and buries her brother to give him dignity. And it symbolizes how the fight to give legal processes some dignity and humanity. So the tension we thought that was an appropriate title. Anyway, thank you so much. I hope I stayed within the minutes. And this is the QR code.
Yes.
Perfect, thank you. So again, there is a reason for presenting this work, because when we heard about it, we were not sure. Is this within the mandate of the reference group? Should this be presented on the reference group? Or this is work where we intersect, but this is not part of our mandate? There are advantages and disadvantages for everything, but there is overlap with the countries we work at, because usually the countries where the ICC would work at most likely are countries where we are also as humanitarians work at. So I want to bring this also for the group to measure the temperature. Again, this is not voting, but to get a sense without spending too much time on a debate and see whether this should be reflected for an activity in work plan in the last quarter of 2025. You want it in or out? Please, members only. No, IOM has two hands. We want one hand only from IOM. Sorry, Guli. Sorry, Amal. One of you need to vote. I think in, yeah. Yeah, thank you, Inka. I think it should be in atrocity, crimes, and MHPSS. How, I don't know yet, but this is for the reference group to discuss in a longer session, whether this is about webinar, whether this is about joining, I'll come to you, Mary, whether this is about joining the group, whether this is about a joint group between ICC and IC reference group, whether this is about a draft guidance document. I really don't know, and I don't think we can reach an easy decision now. It requires at least good 2-3 hours of discussion by representatives. So you will find a work plan item on identifying what are the next working steps on integration of MHPSS into justice system and also accountability mechanism for atrocity crime. Great work, Anne, and thank you for opening our sights on a topic extremely important, overlap with our work. And welcome back also to the reference group after the excellent action sheet you wrote for the ISC guidelines. Marie, you want to say something?
I just wanted to mention that I had the privilege of meeting the UN Special Representative on Children in Armed Conflict last week. She came through Denmark. She was gonna advocate to the government of Denmark to take a stronger stance on children's protection, which they currently don't have in their writing. So it's like, yes, you go. And when I hear this very important piece and your wish to have standards within the work that you do, a question that comes up, what are the links between the International Criminal Court for all people and the grave violations on children's rights? Because I think some of them overlap, right? But you have the child focus and you have all population focused. And to ask if there would be a priority also to include standards that touch on the people in the world below 18, because obviously that's a specific age group and considerations. So.
Yes, thank you. Thank you. It's a good question. It's a big question as well. And just to say, we work with the Office of the SRSG on training. So we provide an input on this in their trainings they do in Ukraine. So there is an overlap. You have to look at the ICC and you have to look at the Rome Statute system. What this is doing is actually looking at the Rome Statute system, meaning like what are the rules in the Rome Statute and how can they be used not only by the ICC, because we are a very small niche in the whole world of accountability, but how can we make sure that what is the basic rules, how can they be applied in other systems, etc. When it comes to children, for us, children are addressed in the book, but as part on vulnerable groups. So it's not specifically on children, but children is one of the vulnerable groups which certainly require, obviously, the specialist support, etc. When it comes to interviewing and support, etc. So for us, I always try to have an integrated approach, so the children are part of it. Having said this, we were just talking with the UNICEF colleagues that there are a lot of initiatives already also at the court because we expect more cases where children are also called as witnesses, more focus on how conflict affects children. So in terms of outreach, in terms of support, in terms of interviewing, there are a lot of initiatives on the way to improve our capacity to handle children. But I think it's too early to say, but probably the standards would include specific areas on children in terms of consent and assent and these things. But I think we would strive to one set of standards which covers the whole thing. Yes. Thanks.
Thank you, Anne. Thank you, Marie. Now we have 5 minutes for the next session, not directly linked to this, but this is for all-time favorite, everyone favorite topic, which was a session of yesterday about localization. And the colleagues want to give a 5-minute briefing. Everyone I meet, they say our favorite session was localization. What did you do, Maria, in that session?
Thanks. I don't know if we can show, I've been sending a Word document. I sent it to you this morning. I think I sent it.
Yeah, no, we've had some issues with the Red Cross.
Okay. So, Or I can just maybe read it out.
Some colleagues has a problem with accessing their email from here, their corporate email. If you can read it, and we promise we share it through the email from the reference group to everyone.
Oh wait, here. I received it like 2 minutes ago. What do I do now? I don't
If you want to read it on your computer, we'll get it on the screen.
It's easier if we can have it, but. So no, just very quickly, I requested to Fahmi if we could just have, give you a feedback a little bit of some of the proposition we received yesterday. So the question was, what immediate step can we take or is in our role as IASC reference group, MHPSS reference group, to create equitable power sharing in MHPSS localization. So actually, it's interesting to see that some of you responded exactly to the question. Some others just like listed, actions that would be nice to think about, but not necessarily has to be led by the reference group, right? So we have different, I've tried to cluster them. So we've got one piece that looks at strategic leadership in localization, saying that we need to set, if we start looking at that, we need to set priorities for localization efforts. Defining which area we need to look for. Is it like funding, service delivery, or research that we should prioritize? And aligning that, of course, with the mandate of the reference group, provide clear guidance to members and stakeholders on integrating localization in humanitarian strategies. Okay, here we go. That's going to be quicker. Maybe I don't need to go in all detail, but the second point, develop localization framework, just a bit up. Yeah. Lead the development of localized MHPSS frameworks in collaboration with national actors and local communities. Of course, I don't think here when we say lead, it should be the reference group, right? But I think that is, the idea is that we should be looking at that type of activities. Establish criteria for differentiating locally led and locally informed initiative. Then there's a whole other piece, quite big piece, that we're looking at power sharing and decolonization. The idea was, yes, maybe to open the discussion with workshop, looking at unpacking colonial legacy in MHPSS. What does it mean? Support the adaptation of MHPSS concept into locally meaningful, actionable frameworks. Conduct power analysis. Promote inclusive leadership and make sure that there is representation of local actors, including marginalized group in decision making, also within the reference group. Ensure local MHPSS practitioners are part of global conversation and have leadership opportunities in global platform. Quite a lot of inputs on knowledge generation and how, in terms of making sure that we engage also in co-creating training material that reflect local realities, but also build on indigenous knowledge. Support capacity development. Just scroll down. And this is where, again, what I was saying about knowledge generation and capacity development. Advocate for donor funding towards pre-service training and long-term local capacity development, including and involving local experts. Create accessible platform. And then we have a whole other piece with a lot of input also we received around donor advocacy and policy influence. We know that this is at the heart of the challenge. Engage donors to promote localization, prioritize local leadership in funding decision, design and implementation, propose adjustment to RFP processes to ensure local organizations are involved, work with donors to make reporting and accountability mechanism more flexible, allowing local organizations to align and to be involved. And then coordination and cross-sector collaboration. That means really looking also how do we work at the level of national working group, integrating localized approach in our strategies, collaborate across clusters, and then a last piece around accountability and evidence-based practices. Of course, I mean, looking at accountability mechanism, champion can contextualize evidence, and finally, a few points around inclusion and what does it mean, link with the IASC MHPSS reference group about in terms of representation, right? About accessing this space. So, I mean, of course, there's a lot out there, and it's interesting because we were reflecting with Nancy and Ananda. I mean, there are a lot of things that also have been touched upon when we had this panel discussion earlier in October. And I think that for us, what we see as probably the next step would be to have more time to engage in this discussion. And as we were suggesting already, Nancy suggested yesterday, I think the best would be maybe to propose to have a space in January where all interested organizations could join, and for starting to discuss, what could be the place, what should be the place of this topic within this group. Is it, and I'm not convinced it's the best, but is it to have a working group on that topic? What would be the outcome? What would be, or are there other ways, of integrating and pushing forward for this topic within the reference group, transversally maybe? This is things that we need to discuss. And obviously, something I want to share is that even if, for TDH, this is clearly, I would say, a priority in our MHPSS work in the coming 4 years. But obviously, we are really also very happy to be able to link and to, a different agency I know have also that very high on the agenda. And the idea is really to come together and see what we can do to get together on this piece.
Thank you so much, Marianne. Thanks for the team. I know that Philippe wants to say something, then Guli wants to say something. Please, colleagues, and then Anne. Colleagues, please, 1 minute max, because we are a bit behind the agenda, and there is important work that need to be done also on work plan. Philippe, okay.
I just want to ask if this can be shared. Can you share it with us?
Yes, okay.
Thank you,
It's going to
Philippe.
be in the minutes,
Yeah.
no problem. Yeah.
Thank you, Philippe. It's very clear. Anne, please. Yeah.
And maybe this is coming, but just a question to the co-chairs, if this is also going to be quickly voted on, if it will be in the agenda for the coming year.
I think the group is clear. We need to put it on the agenda. I see the interest. I don't need to measure the temperature on that one because it was very obvious that everyone liked. But what I'm not sure whether a thematic group is what is needed or not. So I think we discuss how to shape it in the work plan at a later time. But I think the appetite for the topic is very clear. I don't need to measure it in the room. Guli, please.
It was really much on the same line. If it is a working group, then it has to have a product, and the product has to be approved only by few agencies, which goes against the concept of localization big time. So probably that's not the best venue where to have something because of the power dynamic within the group. So that's, that are intrinsic to who we are. So that's.
But definitely, I think it should be in the work plan. What is the deliverable? How it's shaped? I think everyone agree. There is an interest in the topic. Can we do the people with lived experience? I may invite Zainab. I may invite Julian, please. We're missing Carmen also, who was very much interested in the topic, which had to leave yesterday. But we included her inputs into the slides we are going to share.
Oh, great. So I'm going to kick us off. This session is really to focus on the critical theme of engaging people with lived experience in MHPSS programming. And it's really a moment, an opportunity for us to think collectively about how this group, the reference group, can really be more mainstream and systemic in the way that we are engaging persons with lived experience. Sorry. No. But first, let's talk a little bit about what actually engagement in programming actually means, and maybe we even start earlier about who are we talking about when we say persons with lived experience. Are we talking about persons of lived experience of mental health conditions? Are we talking about people who have mental health conditions induced by emergency, pre-existing conditions, persons in institutions? Are we talking about broader communities who are impacted by emergency, including young people? Do we use this term, persons with lived experience, to describe the totality of what we should be doing as a reference group? So that's something that's important for us to think about collectively. The second is engagement in MHPSS programming, and what does that actually mean? Are we talking about the broader kind of cycle of programming that includes program design, service delivery, but also advocacy and policy, which is central to programming? So it's important for us to think collectively as well about how we define that for ourselves. And of course, a lot of what we do is already grounded in international frameworks. You know, we have the Convention on the Rights of Persons with Disabilities, the International Humanitarian Law, and of course, clear intersectionalities between the two that really have already guided a lot of what we have developed as a reference group. You know, we have the IASC guidelines on MHPSS that speak very clearly to very specific groups and vulnerable groups and how we engage them, how we are including them in MHPSS programs. For example, the IASC guidelines, we still refer to the action sheets on how we support persons in institutions, even though it's actually an issue of contention in humanitarian response. We have, of course, the IASC Disability Inclusion Guidelines that was developed by the IASC Disability Reference Group. And then we as a working group, well, the working group that disbanded last year that was focused on disability inclusion, we developed the IASC Information Note on Inclusive MHPSS Programming, which is fantastic, which includes a set of clear actions on inclusion within MHPSS programs. And Julian will update us a little bit on how that is being further operationalized through training materials and so on. And of course, we all, very clear, no need to say, we're all guided by SPHERE standards and core humanitarian standard on quality and accountability, which also speak to values around inclusion as well. So before I hand over to Julian, I also want you to exercise your brain juices a little bit and think about where are we starting? We already have developed a lot of things. So we do have the disability and inclusion IASC information note. So we do have a reference and a base in terms of guidance. We also have the advocacy working group. What role does that play in helping to elevate lived experience in advocacy spaces? We also have the men and boys working group from the gender perspective. We have, historically talked about the role that men and boys working group and the intersectionality that it had with our disability and inclusion working group. There's also the peace building working group, and Ananda, I know that there was a conversation very recently within that working group around how can that working group create spaces with young people or local NGOs and having them be represented and contribute as leaders within that working group, noting that young people are often at the front line of peace building efforts. I think that's a beautiful example of mainstreaming engagement through our existing working groups and platforms. And of course, the multitude of other existing products that exist. So I'm going to leave it there and hand over to Julian, but I think ultimately what we want to do together is think about our kind of collective work and how we move forward more intentionally on inclusion.
Okay, so as you heard, we used to have a thematic group working in this area. And we decided last year not to continue, which is something that hasn't happened this year, I don't think, with any group, on the basis that we'd finished a certain level of work. But what we wanted now is to transition from that ownership of a group that was largely made up of specialist agencies who were particularly interested in disability inclusion, although co-chaired by UNICEF as well, so a good example of a larger agency. But we want a shared responsibility that Sarah talked about. This should be something that we're all doing, that we're mainstreaming as a routine part of the way we do our work. So we have completed the kind of core document, which is often the product that comes out of these groups. And we spent the last year field testing and developing a training package. A lot of that work was done by Heather Pearson, who some of you know, so I want to just acknowledge the work she did. but we engaged in 3 particular settings in Nepal, Philippines, and Ukraine to test out this, this training package. Now, the key way that this training package is different from many others that you'll be doing is the very deliberate effort for it to be co-delivered with local organizations of people with disabilities. So people who both understand the experience of living through an emergency with a disability, and also where their people are, where their communities are, and bringing disability perspectives into MHPSS, as well as the other way around. So these were co-delivered, this is the Ukraine group in the picture down here, with local organizations of people with disabilities, with the aim also of developing relationships between the different participants in the event, people with disabilities and people primarily acting in the MHPSS space. We have basically finished that package now. So all the learning from those different field tests have been incorporated into a version which already was quite accessible, but we really want to make sure it's very, very accessible. So it's going through a process of being reviewed again. So the World Blind Union has been working with us on this, and we've now got a kind of more in-depth accessibility check to come. But after that, we'll be ready with a package of initially training, but also we want to be propositional about how you, as agencies, can incorporate this more actively within your work. One of the themes of the feedbacks we've heard from all of the thematic groups this week has also been, we've got this package now, but we haven't got any money to roll it out. You've heard that several times this week. And we were trying to be imaginative about how this might happen. And we want to take this approach of the shared responsibility. So we have a challenge for you. And the challenge is for you to be, as members of this group, a group which has taken ownership of this agenda of a more inclusive MHPSS space, to take ownership of your own agency's work in this area. How can you make sure your agency thinks more carefully about people with disabilities in the work you're doing? In the different practical work you're doing, maybe even in governance and other aspects of your work. We want to be able to offer the support to help you to do that on a number of different levels. So first of all, there is a training package, which is essentially designed to be delivered to frontline actors in MHPSS to help them do inclusive MHPSS in the field, deliberately designed to be quite short, potentially to be brought into a meeting where you're bringing people together anyway, or to be done even in an emergency setting as well as preparation. So we can help you to deliver that. But what would actually be better is if within your agencies you had people, either your MHPSS people or your disability inclusion people, who were master trainers, able to deliver that across your agency, not having outside people doing it. So we'd also like to offer this opportunity to have master training for your people within your agencies. And then thinking about the fact that you might not have immediately open-armed welcome of this idea, because everyone's busy doing lots of things, to maybe help you with advocacy, making the case internally for a more inclusive approach to the way that you do your MHPSS work. We've heard about the great success of help desks. And this is the final thing, that we know that it doesn't work to do standalone training and to do one-off things, but we really need to make sure that there's then available expertise and support, both for the frontline people who've received training to be able to carry on doing good practice, but also as an organization for you to build your level of expertise in this. So this is a kind of offer that is detailed with more content in a document which I've sent to Maya and will be distributing to you. So please get in touch. There are some contact details on there, because we'd love to really engage with you in helping your agency, your organization, to take this forwards. There was some talk early on when we finished this about the idea of a kind of big grant, a kind of MSP style, properly funded grant to do this. That hasn't materialized, but if anyone is interested in taking this on as a way of doing it in a more kind of cross-agency way, then we're really happy to discuss that. But in the meantime, I think we do have expert agencies within this group who'd be really happy to help those of us who are in more mainstream agencies to do this. I think it's over to you now, Femi.
I put a couple of slides with titles, and the first one is about the IASC reference group, current work plan, not future work plan. The current work plan we have until August 2025. In the current work plan, there are activities to build the capacity of technical working groups or to build the capacity of DPOs in countries where there are active technical working groups to be engaged in technical working groups with an ambitious target that in the coming couple of years, we reach the capacity with at least one DPO co-chairing an MHPSS technical working group. With the aim that also in the coming 2 years, we reach the capacity that we have a representative of a DPO sitting within an organization for people living with disabilities, represented here in the IASC reference group. We currently don't have any. We talk about people with lived experience in emergency. We have 0 represented of these organizations. The development sector is doing much better. In the development sector, more and more, there are people with lived experience presented in global meetings, in summits, in opening. In humanitarian sector, we talk about them. Rarely we engage with them. Technical working group, you look at the invitee list, we travel to countries, we go and see them. Most MHPSS technical working group, DPOs are not represented. But the dilemma is that they are not represented and not co-leading and not here because they don't receive capacity. So one possibility is building the capacity together. We have this activity in the work plan. The idea is that CBM played a key role in the previous year. You may remember that when we developed the disability inclusion guidance note, at that time, what started it all during COVID-19, the Zimbabwean Blind Mothers Foundation, who adapted the My Hero Is You in Braille, so that the blind mother can read in Braille My Hero Is You to their children. And then they were eye-openers for us. We started to adapt all our material in disability inclusive manner. And we kept them, and it's still on our webpage by the Zimbabwean Blind Mother Foundation. They got upset from us because we started to do things in Braille outside them, but we still collaborate with them and validate all the material because they are the ones who started it all. But then we did also material in easy-to-read version. We did material adapted for people with cognitive disabilities. We did material also for people with other sensory disabilities, including video materials in various languages, including indigenous language and Braille and other languages as well. So basically, this work was done with CBM that facilitated the reference group through subcontracts with the World Blind Union. We still have resources to do this work with CBM and other organizations. We will work with you. This is work which is not in the future. This is current work plan work, that we will invite you to sessions from now until August to kickstart this work with your respective agencies in the field to see which country we select together to implement this work with CBM or other partners. But why do we have this session? This session on the agenda, when we suggested to agencies to have sessions in the IASC reference group, WHO suggested a session by Mark van Ummeren, who is not with us, and asked me to include this session on his behalf. So Mark van Ummeren would like to propose on behalf of WHO to have a thematic group, not focusing on disability inclusion, but focusing on people with lived experiences, to include the following topics. People with lived experiences related to humanitarian emergencies. Basically, people exposed to traumatic events that we talk about and the effects of war, but we don't have any of them talking or coordinating the representation, including in this meeting. Second, for people with pre-existing mental health condition that also we talk about. These are 2 different groups, both living with mental health condition, but one war-related and one not, but both are very relevant for our work. And we never hear from them. in a coordinated manner through this group. And third point, for the issue of people living in institutions with psychosocial, intellectual, and cognitive disabilities. We had this in Ukraine. And it's not about only deinstitutionalization, which you cannot do in the first week or 4. It's about the staff that flee for their life, and these people being forgotten for their basic needs, for shelter, for generator, the same that happened in northwest Syria. We think there is an appetite for this group. We are not going to vote, but every group has voting. Unless we reach the quota of 5, the group will not be formed. But we think there might be appetite. We see there is interest in the topic. And this is not about WHO co-chairing. We might actually, as WHO, now I'm wearing Mark Van Omeren hat on his behalf, we might end up co-chairing it. But actually, this is about proposing the group, just like any other group that we put on the agenda. So for you to know, in the work plan, most likely there will be a group proposed on engaging people with lived experience, looking at the current and future work plan. And also, if we don't reach the quota, we will not have a group.
I'm not sure I understand. Do you want to have a group with representative where they will be invited to share about their own experience? Or do you want our agency to be more involved into seeking to work with persons with lived experience to improve the quality of our... Because I'm a bit lost between...
I hope you're not lost.
Well...
This is like any other thematic group. When we suggest a thematic group for livelihood, ideally, you need to have people who is working on livelihood engaged with your group. But the main idea of any thematic group is that you have group from the reference group, member and observer agencies, putting a topic or a task on the agenda. And this is the idea, engaging with people with lived experience, talking about disability inclusion, talking about institutions, including institutions for psychosocial, intellectual, and cognitive disabilities. And also, this group should ideally practice what it preaches by having people with lived experience being included, just like any other thematic group.
So that means you prefer to have one representative who is coming with their own story, or is it about also opening to organization of persons with disability?
The group will not be the venue to share the stories.
Okay, so that's
the group will establish the process that in every meeting, it's not us talking about them, it's about working with people with lived experience. This would not be the main venue where we hear about the stories. This is about putting the topic on the policy agenda of the MHPSS reference group, finding mechanism for more engagement of people with lived experience. But of course, we cannot do that without their engagement.
You said at the beginning of this meeting that, that groups need to be task-based, so that they need to have a product. No? That's basically what we understood. No? Is this the same for this group?
Yeah, it has to have concrete TOR and concrete deliverable. And it should be as concrete as, by the end of this group mandate, we have one agency representing people with lived experience in the reference group, so capacity building done in the field. By the end of the mandate of this group, we need to have at least technical working group in the field, co-chair. That's a very concrete target or deliverable. But this is for the group. When they meet, if the group is formed and TOR agreed, that they start putting the tasks for the group and the deliverable. And the deliverable will not necessarily be guidance document, but would be specific target deliverables for the field to change the agenda on the topic.
So you have a second question, and then I will stop. So rightly so, Zainab was saying that MHPSS is on 4 levels. So the experience on the 4 levels are different, and so who is a person with lived experience? So now we are talking about people with experience of mental disorders, right? So we are limiting to
people with experience of mental health and psychosocial needs during natural emergencies, armed conflicts, and public health emergencies. And second, people with pre-existing mental health conditions who are living in the community. Third, people with mental health condition who are living in institution and have no voice in humanitarian emergency. These are the 3 categories. But again, these are the topics for the group to decide what would be the definition, because I don't think we have a definition right now. Yeah.
Just to say as well that this group, we're not new to, we've been talking about this for a very long time as well.
Yeah.
I think we've been historically, Julian and myself have been trying to advocate for broadening the Disability and Inclusion Working Group. I think that was our intention last year when we disbanded, when we discontinued, because we already saw that there were so many connections with all of the other working groups and what you were doing. So I think, I agree, I think we need to think about what this working group will, the terms of reference in defining persons with lived experience, like you're saying, Guli. I don't think we're there yet. I also think that we historically have been talking about other intersections like racism, like support for LGBTQI+ communities. So I think those warrant a continuity of discussion because there are things that we've been historically talking about, and I don't think they have been resolved between us. So using the working group as a platform to really define what those issues are and what the deliverables could be around those as well.
Thank you, Zain. I'm dreaming more rather than definition and conceptual deliverable than operational deliverable by actually engaging people with lived experience by having target. But I think the group can discuss and we can have, if we have a group, because we may not ever reach the quota. So if the participants of reference group don't want a group to be established, I think it should not be established. But we still have these activities as part of our current work plan. Philippe, then Anne, then Fiona, then I think each 1 minute, please, and I think we need to end the session.
My first thing was the question about what Zainab said, if that was still on the table and if that was what you were meaning in terms of broadening out for those other intersectional things, because I think, right, that has been historically a very important conversation here. I agree. And then the other two things are maybe just a little bit provocative questions. And one is, if we are including things that are more intersectional, like power, that perhaps broadening the membership to include community-based organizations, if we're already talking about including people with lived experience, where is that line? And that might be an interesting thing for the group to include. And then also just to still think about our own language around us versus them and think about all of our own lived experience and our own diagnoses, if we're going on that end, or our own experience to war, et cetera, as a part of this conversation. Thank you.
Great points, Anne. Thank you so much.
In our project at GIZ, we worked on a short paper on MHPSS and disability inclusion in which we explored conceptual terms and definitions. It's on mhpss.net, and if you haven't seen it, I encourage you to check it out. And there's an organization called Justice for Mental Health, a Lebanese organization that is basically, it's an organization founded by people with pre-existing mental health conditions, and they're part of our national MHPSS task force, and they're consulted every step of the way. So this could be also an organization that could be good to join this group.
Very active in this work, and I think would be a key actor in this interaction, whether or not we have a group. Fiona, please.
Yeah, just an additional that we always leave people living with a neurodiversity, people living with autism, dyslexia, and ADHD are not considered having a disability, and they don't consider themselves as people with disability. It's really important that we start including them, particularly because there are many children out there in humanitarian setting living with autism, ADHD, and they are normally left out. So I really encourage that we consider people with a neurodiversity as part of the discussion.
I agree and makes sense, Fiona. Colleagues, I want to also make sure that what we put in 2 slides are 2 different topics. We have in our current work plan activities that we need to do in the short term until August 2025, which is related to engagement, people with lived experience and technical working group, and ideally as observers in this group. Currently, we have not implemented this activity. And to do that, we need to talk together to identify who to engage. While we are doing that, we may decide that we want in the future to have a group on this topic beyond August 2025 or not. And that's what we discuss here as a proposed activity. So you will find communication from us as reference group co-chair on the topic. That does not mean we are having a group. That means we are implementing the current work plan. But if we decide and we vote a group in the work plan from August 25 beyond, I think that would be likely a good idea. I think we stop this now. This is for later discussion, and we have a coffee break now.
Yes, and I would suggest we take a 10-minute coffee break. You can take your coffee and you can bring it inside again. Okay, 10 minutes. Thank you so much.
I'm confused.
looking for?
The communication was hijacked, it's still a double shot proposal. So double shot wants a group about working committee.
That's easy.
With organizations with
It's easy. I mean, I have people, I have an entire staff who have lived experience. I mean, that's my whole staff. I know. Ananda.
What you mean for
I mean, but they're specifically talking lived experience with mental health. But I would suggest that could also be people sitting in this room, lived experience.
And that's what she was saying. And that's what is the difference between what is used and pre-existing?
Well, I mean, it doesn't, whatever. It's like, but I'm not sure what does that mean? So next year I should send someone from us that is a person that had mental illness due to the war. So that's the person who should come. All right. Now, of course, they can't because nobody who's a refugee can leave Egypt. But that's it doesn't make any sense to me. Yeah, it's because that's not who's here and that's not where you're. So I don't know.
Meet the criteria for any other business. So an organisation
Probably
that sits on the top and joins in. But you also need to find a way of getting our stuff earlier. Who are in the front line of the action environment? I don't think this necessarily needs to be very classical. I don't think, for example, the point that was made about what about the product? I don't think we need to have written products. What we need to do is to guide this group in the complex decision about how we can land where we should have a voice that is thoughtfully consulted, often sitting in a meeting to change at all. But we give that a I don't think there's anything stopping it being a public meeting, but having a dedicated job to it. So the final product is provided written document. It's a recommendation for the IASC for how we go to change our practice to be more. And how we do that in terms of
good night of rest. Looking forward to going home tonight. Yeah, but I'm so leaving tomorrow. Yeah, booked the flights I came in at 11 on Monday and so really just making
it's all right. Brenda will be here soon enough.
Yeah, and I'm going on a vacation on Saturday.
Aren't you the lucky one?
I know. I'm going to go and get some vitamin D.
Very much deserved. Please go enjoy. Where are you off to?
To Oman.
It'll be pretty warm?
Yeah, should be around 30 degrees.
What?
Celsius, around 30.
Oh, 30? Oh, I had 130. Okay. No, you don't want to be there for that.
It's not hell, where are you going?
You'd be boiling, nothing
Yeah,
should be
that would
existing
be a bit extreme.
30 is lovely.
30 is lovely, yeah. So, quick winter getaway. Thank you, same for you. Good luck for your move to Denmark.
Thank you.
I'm sure you will enjoy it.
If I make the move, I'll plan on enjoying it. I will complain less and dress warm more, so that I don't have to complain about the weather.
Yeah. So you will just bike everywhere, with a child on the bus.
Maybe that's what I need to learn when I'm in Kenya.
Absolutely.
Just refresh my memory.
That's what the Danish people, if you want to integrate with the Danes, you definitely have to have a bike and accessibly bike everywhere.
I'm not sure that I'll be confident enough to drive next to some traffic lights.
But I think it's a very good, they have a good bike lanes and stuff, so they well equipped, but yeah, I know, I hear you.
It's just a little bit of confidence.
Especially if you bring the baby. I don't never do that. Like I was like when I see people in Switzerland and they have, you know, the kids and then the cabins and stuff, and I'm always like, wow, that's like wild.
I don't know if I'll ever have the courage to do that.
I'll give it a few years in Denmark.
Oh, and then I'll be like,
No, but can we send an
after lunch is
And then in exchange, giving them what they say, like this one next to the women. And the way to because the way to it's a training site. That's what I had. So that's why I get it out.
No, I mean, if anything, the training package is talked about.
No, the training not that I we need to have that's a bit of a right and then another cycle that I did out as a class.
It hasn't come to me particularly, but I think it's only because it's such a closed space that you can very close space. I think that's what I heard. So I said to the country today, always have this country. They call themselves refugees, not officially refugees. They have their own These are very sensitive issues, but keep your eye on the prize.
There's a lot more to accomplish. Like when kind of very discussed kind of doing kind of step back to see what's and see if there are other strategies that might be more useful or has this idea kind of run its course. You don't know. And we have a lot of people. When they all started, it was some Catholic addresses. More than that. So.
I'm sorry I didn't introduce you as a consultant. I thought afterwards, but then it might get confusing. Yeah, this may be better. You have so many bigger pots. So it's interesting to see where you.
We always put it in the proposal when we submit it. But it's good to kind of reflect about it together and also to think about this and what
So it's not
intervention and like
its own health. But I guess CDC does it. You might be close to about 4 years. I think the CPC is US. Right? Yeah. I mean, I know we have people monitoring. My boss is IPC nurse working in I guess Bulgaria, and she when got sick, was very scared and didn't get it. But she was really very yeah, it's nice to have someone on our team that has something else.
Try it again.
Sorry to get to that. What happened today was I'm not 100% there.
I know, right? I pinged Ina, and she's offline, so she's supposed to be online today. So I've been watching to see if she responds. I just pinged her and was like, hey, quick question, just checking on the timeline for when we expect to leave. It's like, because but nothing to do with that. But I was like, just wondering.
Yeah, nothing happened so far.
No response, but I know she was supposed to be back online today, but her way messed. I was hoping that she'd be like, hey Kat, how's the first group meeting? Oh yeah, we're actually taking calls for this week. Oh, and did it pass and it was good years, and I just want to see how
Against me, and as long as you don't understand, I'm just
I'm still honored and excited for the chapter breath.
And you were like, they just didn't answer. They were like,
As long as they don't, oh, sorry, then there's so much shrinkage.
so we were laughing at
water.
Oh,
This one,
yes,
that could
gonna
be
be
nice. Like, that could be a good next chapter.
But no, I mean in terms of jobs, that's what I was today.
Then you can just add to it.
Hopefully something I'll let you know if she's messaged me back today. You're here tomorrow.
But I didn't get the
just keep checking it. Teammates' messages keep coming in, and I'm like, oh, it's not Nina. I'm like, ugh. Thank you.
Dr. Oz.
Welcome back, everyone.
They just said that Dr. Oz will be the new.
Welcome back, everyone. Let's start, please. Let's invite those who are outside to come in. Megan, Claire, thank you so much. And before we start this session, we need to do something very, very, very quickly that will take a couple of minutes. Please stay with us, please. It will take a couple of minutes, I promise. But please feel comfortable and you can sit if you wish. Do you know that we are being listened to and watched all the time?
Yeah.
Thank you. We have good colleagues and friends online who couldn't make it. And we don't want to forget all of them during this session. So like we took a sample from colleagues talking here to introduce themselves and their work, we will ask the same from good colleagues and friends online. Christina from Doctors Without Borders. Christina, please introduce yourself and what do you do, where are you based, and why are you not here, Christina?
Yeah. Hi, Fagmi, and hi, everyone. Can you hear me well?
Yes, loud and clear.
Yes, great. Thank you for the opportunity. I couldn't be there for personal reasons, so unfortunately, but I have been following yesterday and today, so thank you for the opportunity. So I'm Cristina Carreño. I am based in Spain, and I am a MHPSS advisor for MSF. So as you know, we in Doctors Without Borders, we have been working with MHPSS in health, nutrition, and WASH for many years now, and we work with MOH and other local partners. And last year we implemented around 250 MHPSS programs in more than 70 countries. We do implement multi-layer approach. So some people place us as only doing clinical work, but this is not really true. So we also do community-based psychosocial interventions, and it's a big part of what we do. And we also advocate for the rights of people with lived experience in emergencies, with people with lived experience of mental health conditions, especially psychosis. We have been working with WHO and Carmen HI in the Quality Rights Initiative and the training for humanitarian settings that will come next year. And we also do some research. So if people are interested, you can Google MSF and research, and it will lead you to the science portal. And really, if anyone is interested to know more, so I'm available. And thank you so much. I don't want to take more time because I know we are late. So thank you, Fahmi, and everyone.
We are grateful for your presence and following us, and we really hope we have MSF always with us in every annual meeting. We are grateful also for your support and allowing us to pilot at your logistics centers the quality rights work together with humanity and inclusion colleague, together with the Red Cross and Red Crescent movement and WHO team. And I'll never forget that you didn't allow me, together with Peter Windvogel, to add clozapine to the IHK. I'll always...
No resentment. Thank you.
Christina, anything you remember from the 2 days that you didn't know about before, from following what colleagues are saying? Anything you heard that was news for you?
Well, news is about the new inclusion of I think the new colleagues. I was not aware of that. And the criminal core part of today, I think it's super interesting. All the work with victims, survivors of torture, I think is super interesting. And yeah, I would say all the initiatives also of integrating people with lived experience, I think is super good for us. We were very aware of some of the toolkits of the assessment specifically that have been mentioned several times, and we hope that we can also provide some feedback if we have soon.
Thank you, Christina.
Thank you.
Very valid point. We would like to invite Florence, our good colleague from Catholic Relief Services, to introduce herself and anything she enjoyed also during listening and watching us during the last 2 days, and what CRS do in MHPSS.
Thank you very much, everyone. I'm Florence Nakarutimana. I'm from Burundi, but I'm based in Uganda, in Kampala, and I'm a technical advisor in psychosocial support and well-being in the emergencies. I joined this reference group when Melissa Tucker left CRS, and to be honest, to be part of this meeting since yesterday gave me an opportunity to learn more about what this reference group is about. And I enjoyed everything, all the information provided, and especially I think the section we just closed before the coffee break about how we can support inclusive MHPSS programming. So how we can be inclusive with people living with handicap and other vulnerable people. So, and this touched me so much because CRSC also in discussion about a module to be sensitive on inclusion. So I've been supporting MHPSS activities in Africa, especially in Central Africa, Republic, Mali, Niger, Burkina Faso, and Burundi as well, and Uganda, in Senegal as well. But we also have other MHPSS interventions in the West Bank, in Gaza, and other parts of the world where CRS has offices. So thank you for this opportunity. It's kind of sad that I was not able to secure a visa to be there to see you in person, but hopefully next time. So have a fruitful meeting. Thank you so much. Over.
Thank you, Florence, and wonderful to have you. And we are grateful for CRS, the work you do, also the engagement with many thematic groups. Pleasure to have you, Florence.
Thank you.
And now the floor for Megan and Claire. And thank you for being with us, two good colleagues.
Wonderful, thanks so much. Well, we had a longer session, but due to time constraints, we're going to shorten it and also refine a little bit the focus. Our idea was to really talk about counseling and psychological interventions and what organizations are doing with approaches that go beyond manualized and scalable psychological interventions. So we wanted to create a space to really talk through this, how do organizations decide what interventions their counselors or psychologists might be offering, especially if they are doing something different than the scalable psychological interventions. How do you roll that out? Do you have training materials? Do you train them? Are you going with how they might have been trained at university and supplementing that with additional capacity strengthening? What types of quality oversight? We've talked about a lot of these questions, but due to the time here, what we'd like to do is really just think about how to brainstorm together. What are the best practices? What are the challenges? Are there particular gaps and priorities that we could possibly address across agencies to really better, understand and strengthen these practices? And so that was a joint priority that had been identified by ARC and IMC. Would you like to add to that?
No, I think for the sake of time and to give enough space for the brainstorming, I'll leave it at that. But just to say the top of the pyramid is something that we don't address or discuss often in this group. So it was just an effort to sort of provide a space for that and how can we better identify best practices.
So what we'd like to do is create 4 groups. So you'll work across the 2 tables in each row. We've put Post-its here. And what we'd just like to do is have you share. So, okay, do you have paraprofessional counselors that are doing counseling? What does that look like? What approaches, what training? And then if you have psychologists that work with you, what types of evidence-based approaches are they using? And to what extent are you doing capacity building on that or any kind of sort of mentorship or supervision? And we'll just kind of do it as a quick deep dive to the best of our ability in the limited time so that we can really understand what those practices are, what those gaps and challenges are, and how we could potentially take this forward as different member agencies to strengthen what we do, to collaborate further, and to learn from that.
And similar to the localization conversation, this is obviously just a start. So hopefully we'll be able to share your input back to you similarly to how that group did it.
So without further ado, if you can just kind of merge, you can stand, you can move your chairs, but just merging the groups from 2 tables in each row. And just, we've put the questions on, do you want to maybe just flip that around? We've put the questions on this flip chart here. And obviously for organizations that may not be directly engaged in these practices, you can still obviously contribute as clinicians with your thoughts, your observations of best practices within your organization or former organizations, but we'd really also love to hear from those that are employing counseling and psychological interventions.
So just to be clear, in each row, we dropped Post-its. So the Post-its are at this table. So if, this group already formed, Post-its are already over there. So this row, and then so on and so forth. The questions are written here. So we have 1, what is the state of focused counseling and psychological interventions in humanitarian settings? 2, what are the interventions being used? How do you decide what to use? How are the staff trained? And 3, what are the gaps and challenges?
And so you'll have 15 minutes, and then we'll take the Post-its and we'll consolidate this and write a summary document and circulate it and see from there where we, if or how we'd like to take that forward. What happened?
Or challenges. Yeah, exactly.
issue work on the good and let's say you're planning, or if it's actually on the good, or if it's just going to be on one and just with a visibility, we don't have to respond to all the different gaps in terms of
So with UNICEF, we are developing a manual on psychological intervention coming from the manual that we worked on many years ago. So I just, yeah, but we will finalize it in next. So, yes, integrate the manual intervention, psychological intervention. That takes and so we have clarified what is psychological and what is psychological intervention, and then which context finally we develop and we also have clarified which theories we are using as reference as psychotherapy. So within IASC we have students who also integrated psychology. So that means that we use structural psychology, psychoanalysis, CBT, MDR a lot. We have used some protocol of care based on EMDR and CBT, and we try to compare some the manualized EMDR protocol and we have mix. Such as focus on emotional facilitation. So we do research on that, and when we show that our protocol is enough, it's okay, we promote our protocol in that. We have a supervision. Exactly with the same limits of euros, depending on our human resources, but our PM, our managers are all psychologists.
Definitely will. Can I just say we work on providing information and we'll share with you some and we'll send it out as soon as possible, so without making promises. Okay, great. Thank you so much.
number of topics we have talk about in the period of so quite so in terms of treatment of trauma, there is so we treat some symptoms of trauma, but
In Colombia, we have 10 clinics for Venezuelan migrants coming from. So the health clinic, the doctors, the clinical professionals. Now, interesting thing, the problem they want to have is the Colombian government is now absorbing in places like Bulgaria, one of the clinics first psychiatrists leaving in, that didn't work, and time.
Yeah. So now.
And then eventually develop a way. Some of them are.
No. Did someone say it? I can actually. I will mention.
Also, in the Philippines, very different. Very rural health unit. And we do like mindfulness and pretty none of the other things fit.
Dear colleagues, we have 1 minute left. We know it's a short session, but we just wanted to get the initial brainstorming. Please make sure you're taking notes, and we'll, again, consolidate all of the feedback. Thanks.
Maya, can we go to the next one? Colleagues, it's a very deep topic. We appreciate the discussion, but since we are behind the schedule, I propose we move to the next session, please. Thank you, everyone. Because I know some of you are very interested in doing the site visits, and some still have the steering group meeting, which will continue until late in the evening. We don't want the steering group meeting to continue until 11:30 p.m. So we want to move ahead. Can I get your attention, colleagues, please? Anne, Megan, Marie? Please, colleagues, I'm really sorry. I hate to interrupt this amazing discussion. Philippe, you want to say something? Anything with you, Philippe, is possible. Please go ahead. But very briefly.
Thank you. One, maybe it's related to the pyramid, but not to level 4, rather to level 1. And I'll be very brief, just 1 minute. Being a development agency, our focus is bringing MHPSS from the humanitarian field to development. And we didn't get the chance to talk a lot about this, which I would love to have more exchanges on if possible.
Thank you.
But basically, one of the pillars of our work is in the regional MHPSS project is integrating MHPSS in other sectors. And one of the things that we are having a difficult time wrapping our heads around conceptually is how the pyramid basically relates to this integration in the development sector. And I think that this is it parallel? Is it part of level 1 all the time? And I think that this topic, this exchange would be relevant for the HDP nexus to have. Thank you.
Thank you, Philippe. Thank you, GIZ. We are at the time where we are getting very close to ending the 2 days of the annual meeting and getting ready for the site for the site visits and getting ready for those of you who will join the steering group on Surge this evening and getting ready tomorrow for 2 things. Actually, tomorrow, 3 things happening. Tomorrow we will have another site visit, and we will have the Bulgaria branch, where we really, and Bulgaria and partners here, count on us on advocacy. Please don't skip it. This is important that all of us are there. So we give something to Bulgaria that generously and kindly hosted us. And also opportunity for all of us for interaction with Bulgarian authorities. And then we will have the governance meeting, where there are many interesting and exciting topics, including an election that will happen tomorrow. I want to give a bit of orientation. I see, since I start talking on election, we have many colleagues who are attending the reference group, other as members or observer for the first time. They wonder what's happening in the world. We're coming to an MHPSS meeting. What is this voting, an election? What's happening? So we want to give a bit of background for members and observers on where this all come from and what will happen, okay? September 1st, every 2 years, based on this group bylaws or governance, there is nomination of agencies interested in co-chairing the group, which has happened. It was announced at time, and 3 agencies nominated themselves: I4C Peace Center, and UNICEF, and International Medical Corps. By October 1st, there is announcement of the agencies that nominated themselves, and it has happened. And then, every 2 years, in an event called the governance meeting, attached to the annual meeting, which should happen between October and November, there will be election process, and agencies have to vote in pairs on all possible combination between all contending agencies that has nominated themselves. And this apply only to member agencies. Observers cannot vote. Then handover process would happen every 2 years. Why we so early? if the handover is going to happen in August, September of next year, why we have to do this now and work on the work plan? Because of the budget cycle and because it takes time to fund the work plan. So this reference group need to know in advance by 10 months that a handover process will happen in August, September, and actually based on this, they start fundraising. The fundraising is the responsibility of the coming co-chair that will be elected tomorrow. And that's why we need to tell them almost 1 year in advance. I hope that's clear. We cannot tell them in June or in the next annual meeting, you are going to co-chair for 2 years because it will take them almost 1 year to fundraise. That's why we tell them very long time in advance. And it also depends on the funding cycle of the key donors who are having funding throughout the year because they are humanitarian donor, but the funding cycle that was also inherited across this reference group across ages since it was established in 2007. This is not the first time that this group make a switch in its co-chairs. Not the first time at all. However, it is the first time that this group would have a governance meeting that would govern its election. Also, it's not the first time that this group is doing election. It did election before. But it's the first time that the field has grown to the extent that we need to do a governance document to do elections. The mandate of the new co-chairs that will be elected tomorrow will be for 2 years. That means next year we have no elections, but we may still have governance meeting. The next year, the current co-chair, like what happened with Carmen, present on their previous year work plan and they hand over, but the handover should precede the process of the next annual meeting. We can discuss on the exact date of the next annual meeting to make sure there is a smooth handover. What are the criteria of a co-chair? Should the co-chair come from a UN agency? Should both of them be UN agencies? Should be they members of the IASC? Can we nominate Red Cross agencies? Can we nominate international NGOs? All that apply. Are there restrictions on combination? No, there are preferences. So all are preferences. It's preferred that one health, one protection. It's preferred that one UN and one international NGO or Red Cross or Red Crescent Society. But our governance document, our criteria, does not put restriction that they have to, but put lots of preferences, as you see. If you are voting tomorrow and would like to know more about the criteria, please read the governance document. Please read it carefully so that you make an informed decision. But most of what's in there, based on UN versus non-UN, are strongly recommended, are preferred. But if the result tomorrow does not include a UN or does not include a Red Cross or Red Crescent agency and does not include an international NGO, the result will still be valid. This is our governance document, and it's open but has many recommendations. Colleagues, in the last 2 days and before, I received many frequently asked questions. And I compiled in a couple of slides all the frequently asked questions that I have been asked. And believe it or not, these are the questions that I was really asked. Exactly, I'm using verbatim. And I'm going to share with you because some of them I got asked around 4 or 5 times. Okay? And I decided I'm not going to create a thematic group for mental health support of former co-chairs. So I'm sharing all, I'm sharing all with you so that also we answer all the questions in public because many are very important questions. Why are we having elections? Clusters don't have elections. Yes, but we are not a cluster. Health cluster do not have elections. It's usually the health lead. WASH cluster, it's usually UNICEF lead. Nutrition, usually UNICEF lead. But we are not a cluster. We are a multi-sectoral area. And I think it's healthy to do change in the group, like what this group has always done. Whether the group decide or not to do elections, the group decide to do elections. My agency decided not to be part of the elections, but the group decided to be elections, and election it is. I think it would be good for the group to have diversity of various sectors and cluster and UN and international NGO and Red Cross and Red Crescent. I think for the area, the democratization of MHPSS we have done, I think it's healthy. but we are not a cluster, so we need to find the selection mechanism, and the selection mechanism we currently agreed on is election. Ananda. Yeah.
Voting was brought in 2015 because there needed to be some transparency to the group so that you knew how the system worked.
Yeah.
And now, and that was still quite a simple mechanism.
Yeah.
And as you said, it is now evolved to actually know some rules that everyone can see. Yeah.
I'm proud with the work I did together with Carmen to bring us here, because we drafted a governance document. You suggested process, we developed the process. So I think I'm proud with what we have reached so far. Why can't observer vote? We come to this group. No, we follow a membership criteria. Some observer, we wanted to be observers, and one of the key differences according to our bylaws, governance document, between members and observers is the voting mechanism. So observers cannot vote. Observers would include, there are some entities that will always be observer, which are donors, for example, academic entities. This group is from Humanitarian Operational Agency. So the decision is that only members would vote. But you know what? Look at them. All the colleagues nominating themselves are really nice. Who can we select for this election? Look at all of them. They are all our friends. We go with them for lunch, for dinner, for drinks. I don't want to upset anyone. Why we are having this election? You should not upset anyone. And you should continue going with them for lunch and dinner and drinks. And you are not voting for them. You are voting for agencies. And that's the difference. This is not the interpersonal reference group. This is the inter-agency, and you are voting for an agency. And I hope tomorrow when you vote, that does not judge by how nice the smile of the person or how nicely dressed they're coming to the meeting. This is how the agency mandate should be, and how your agency mandate fit with the agency mandate you are voting for, or how you think the agency has the capacity to implement on the work plan and represent the group in the humanitarian system. But it is not about how, because people can change. None of the agencies that put people for nomination tomorrow are having obligation to maintain the same people across all the years. So a nice person may not be a nice person the year after. But the agency will remain the same that you have voted for, and would be difficult actually to change. They will not nominate person. Tomorrow we are voting for agencies and all the combination of the three contending agencies. Another question, can I vote for an agency that did not nominate themselves? You can try, but likely that does not. All these are questions I got. Okay, but we're having voting, and we need programs of work. Do the contending agency present the electoral work plan for the coming 2 years for the field of MHPSS? No, of course not. Because we agree on the work plan here. They will not come up with an idea like, I want to emphasize medication distribution in emergency for the next 2 years. No, they cannot come with that, because the work plan, you agree on the work plan here. And we share with you for validation before we start the implementation. So the work plan is the work plan of the ISC reference group. And agencies don't need to present their own work plan or their ideas about an ideal work plan, because they need to present what we agree on here for the coming 2 years. I'm continuing with all the good questions, colleagues. All are very good and very valid, I think. When the current work plan ends? December 2024? No. The current work plan will end in July, August next year. I'm using July, August as a flexible date for the handover, because it may not work that we do a handover where everyone is on holiday and then the group is left with a gap. So I think the coming co-chair need to sit with the current co-chair and agree on an exact date that should not pass and exceed 1st of September 2025. And 1st of September need to be a deadline, because the hosting agencies, the current hosting agencies of the co-chair position, will not have funding beyond that date to maintain the work plan, neither for the co-chair position. So despite 1st of September, immediately after the summer holidays, but there will not be funding and there will not be work plan implementation, and requests will come and there will be no support provided. And that should not happen. So whoever will come in the co-chairing position need to have funding and co-chairs in position by no later than 1st September 2025. And the exact day of handover between July, August need to be decided, ideally before we leave Sofia. Okay, you presented on day one that there are maybe 100 consultants and staff working and supporting the IC reference group work plan. Are they all moving to the new co-chair agency? Right? They are all working for the IC now. Are you moving them all, the 100 consultants, move on 1st September and go to the building of the new? Nobody is moving. We didn't receive anybody when we started the co-chairing from anybody. Every agency has its recruitment process. The IC does not have a bank account. The IC does not have a recruitment process. There are co-chairs in agencies who start the recruitment process based on the agency recruitment process. Some of the consultants, of course, if the function persists in the new agency which co-chairing the group and the announcement of position start, they may select to join the new agency. However, we are not moving like a Google Drive, all consultants and staff. People may apply for the function, for the consultant, when the jobs are created. But the IC does not have a recruitment mechanism. The IC does not have bank account where people receive salary from. These are jobs created within specific agencies based on the agency recruitment process. And the recruitment process in UNICEF is different from IMC, is different from WHO, and each agency would need to announce. There is no IC contract which is transferable. When WHO started this 7 years ago, we did not receive any staff from the previous hosting agent. We did not. There was no one. People stayed with their agencies. And another question, are you now transitioning? This was about me. I'm not transitioning to anything. No, I'm not transitioning to, are you moving? No, I'm not moving, I'm staying with WHO. I'm playing a function. I was with WHO before, and I'm fixed term in my agency. I will continue, but likely play another function, another role. So are you in transitioning mood now? No, not yet, because I still have work plan to implement for 10 months. So as far as I know, I'm not transitioning now. I may transition the function closer to date and start the handing over process. What will happen to you in September? No, I still will be me in September. What will happen is stay with WHO, likely playing another. Do you know what will you do in September with WHO? I mean, depending on my supervisor. He gives me a new task every day. So depending on what will happen in September, I get new tasks, but likely I'm staying with it. Will you move if there is a new opportunity? Yes, just like you. If there is a new opportunity, nice, I may move as well. But I'm not transitioning. I'm not in metamorphosis on any kind of anything now. I'm answering all the questions. Will you continue to be personally at the IASC MHPSS reference group? Yes, like Carmen was on day one. And if the agency decide to nominate me to represent WHO in certain sessions, and that apply to the co-chair of Thematic Group or representing WHO in specific session, like accidentally Mark was not here, I may do that. If not, then like what Carmen did, I attend day one and then leave. Where is the next IASC MHPSS reference group annual meeting? Will be there an annual meeting, and when it will be? We don't know, because we don't know who is the host yet. And none of the new reference group co-chairs, ideally when there is a new co-chair, it should be hosted by the co-chair agencies. That depends on many logistics, where it would be, but it's a decision for the coming co-chairs. I think ideally the date should be advanced by a month to match with the handover. So there is logistically an actual handover between the former co-chair and the new coming co-chair sometime in September. But the normal date is October, November, like where we are now. Where it will be, that's a decision of one of the three agencies, I4C, IMC, or UNICEF, depending on the result of the election tomorrow, where and when it will be. Otherwise, a non-co-chair agency can host, like GIZ generously hosted us also last year. So if a non-co-chair agency is deciding to nominate themselves for hosting the next meeting, they're welcome to do so, but so far we have not got that. If no agency stepped and proposed to have an annual meeting hosted by them next year, we will not have that. We will not have an annual meeting because that's a decision to be organized by the co-chair, which should be starting by 1st September 2025. Okay, this is all the questions I got. Colleagues, do you have any questions now before we talk about the work plan?
It would be ideal if this year we have one of the other agencies offering to co-host so we solve the problem.
I think we discussed the next annual meeting in the governance group, and ideally, if there are a number of nominations, we propose it. But I think also there will be a bit of clarity depending on what is the result of the election tomorrow. Leah. Great point. According to our governance document, the budget comes from various sources. So agencies who agree to be part of the reference group need to nominate time of staff, like time of all the staff sitting here. This is time, and time equal money. Agencies also throughout the year engage in activities, and that's equal money. Activities mean reviewing a document, clearing a document. And that does not come from the reference group budget, come from agency responsibility. Some of the agencies co-chair a thematic group. According to our governance document, the co-chair agency has the mandate to raise funds for the thematic group. If you think a topic is important and you want to put it on the agenda and you want to co-chair it, please try to fundraise for it. And if there are no funds coming, why did you suggest the topic? But however, the challenge is that some topics do not come on the agenda unless you put it in a thematic group. That's why it's not that easy and not that direct, and some topics can be classically underfunded. So it is the responsibility of the thematic agency. However, we have incidents where we managed or we struggled to fundraise for a specific topic, like what we shared with you on the substance use group or the peace building group. And actually advocacy or joint forces between agencies managed to allocate small amount of funds. There are topics that get easily embedded into the work plan of the reference group and get funded by the main donors, which is particularly USAID, BHA. It depends on the topic, the donor mandate, the agency mandate, the availability of resources, the link between the topic and the humanitarian field. Okay, finish all the frequently asked questions. I think now, WHO will not be responsible for the work plan between September 2025 until August 2027. So I'd like to invite Zainab, Claire, and Terry, who will be leading on that work plan, to go through the previous activities, what we discussed, have a brainstorming session now about the work plan for the 2 years starting from September 2025. Please, colleagues. And if we can put previous work plans, have a discussion. It does not have to finish now, but a little bit of brainstorming about activities and priorities for the coming 20, 30 minutes. Sure.
Are we missing Sarah? No.
Terry will represent IFRS.
Oh, Terry, sorry.
And colleagues, I'll back you up, but please take the pleasure.
Am I starting? Oh. I mean, I think you said, Fahmi, first of all, thank you for letting us stand before you, and it's great to be humbling to be nominated. I think it's fair to say that Fahmi, Terry, Carmen have done a spectacular job. I think even looking at this working group, listening over the past 2 days, the accomplishments of the co-chairs, accomplishments of the working groups, of the different people who are engaged at so many different levels, it's honestly, I'm in awe always. I was in awe last year, I'm in awe this year. There's so very big shoes to fill. So I think regardless of what combination comes through after tomorrow's election, I think we have a lot of work to do. So thank you, Fahmi, really, truly, Terry, everyone. I think it's been fantastic. And Terry, maybe you'll continue to lead us. Yeah. I don't know if anybody wants to say anything as well on this. Yeah.
No, just to echo that, the leadership has been so tremendous. It's really been so inspiring, and it is an honor and a pleasant surprise to be invited to reflect with all of you. So thank you for that. And as Zainab said, 3 really fantastic combinations. We'll all fully support whoever all of you vote for, and throw our support behind it. So I know we have limited time, so shall we?
Yeah, colleagues, it's difficult to go through activity by activity, but I think use the opportunity. Sorry, Terry, you want to say something? No, of course, no, Terry. Terry is, yeah, please, Terry, you want to say something?
Not really.
Okay.
I don't know why I'm having 2 mics, but yeah. Maybe then you can hear me clearly. But to just really appreciate the opportunity that you have given IFRC to be the co-chair of the reference group for a few years now. And it has been a pleasure for IFRC to co-chair these sessions and to co-chair the reference group. Of course, we would love to continue in this same capacity, but from all the presentations that have been made, especially by Fahmi this afternoon on the criteria and everything, it's really up to you, colleagues, to do to decide or to vote for whichever agency that you feel is going to help take this the work of the reference group forward. As you can see, there is a lot of work still to be done. There are lessons that we have learned. There's still more to be learned and to be done. And the ball is really on your court to go ahead and choose the favorable agency for that. Thank you.
And if I may suggest, Fahmi, I think, like you said, a lot of things are going to be contingent on the results of the elections tomorrow. And I think it's important for colleagues here to know that, whatever the combination, I think we will honor the work plan that we need to continue to work on through September. We will honor the work that has already been done by a lot of you and how you see that work moving forward. So I don't think really a lot will change in the immediate, I think it's about thinking through strategically once we're given a true in-depth, we have conversations within the working groups, more broadly through some maybe in-depth discussions around priorities. I think yesterday you put up a slide that said, Carmen put priorities, challenges. I do think it warrants now perhaps opening it up to everybody to walk us through some of those things that you're thinking. What are some highlights from the past 2 days? What are some challenges that you would like to see the new co-chairs, prioritize over the next few years?
I agree, Zainab, and I don't think it's fair to go activity by activity in the last year, in the current work plan, but I think this is a time for the coming 15 to 20 minutes to brainstorm a little bit what the group would like to see starting from September from the coming 2 co-chair agencies, which we don't know who from the 3 agencies, but definitely it's not us. So it's not fair to us as WHO to currently facilitate this decision. So get a bit of opportunities, look at the previous work plan. We discuss things that are recorded and will be included in the work plan, such as the ICC and the link with the justice system, the clusters that we don't work on. This all will come in the engagements with people with lived experience. But I think this is an opportunity to get a bit of insights so that to feed into the work plans that will be validated. So floor is yours, colleagues, for the coming 15 minutes for brainstorming.
Would anyone like to start? I mean,
You're one of the 3 options too, so you should.
I guess really let's have an honest kind of open discussion. What are your thoughts about this working group or this reference group, how it moves forward? I mean, I think one of the things that stands out to me are the technical working groups. For example, I know that has been such a huge accomplishment of the reference group in the way that we support the technical working groups. I know we got a chance to listen to that yesterday. I don't know if we had a time to actually discuss the role of the reference group in supporting the technical working groups and the different modalities for that through Surge, through the co-chairs themselves. Maybe that's something that would be nice to reflect on because it's such a core component of the work plan.
Absolutely, absolutely. There's a question over here, yeah?
Yes, one of the members would like to contribute. Please go ahead.
I have a process question, since we've just talked through a lot of governance, which is super important. In the spirit of ground-up approaches, I think it would be super interesting to hear what thoughts are around turning it upside down a bit and see what are the technical working groups' priorities and how can they feed up to the reference group, because we're here only to serve what happens on the ground, and knowing that there's a mix of actors on the ground. Some are there for longer, some are the local ones or the long-term INGOs, and some are there for shorter. But I think it's to just bring that question in and think about how can we hear it from the crisis level also for the work plan.
Absolutely. So perhaps sending out a survey and doing some consultations to hear from them in these humanitarian crises. What are the priorities that they are identifying themselves, and for us to then discuss and reflect how can we best meet those needs and support them. I would fully agree with that proposition.
I just want to extend that conversation a little bit. I think we're talking about agencies who are primarily involved in responding to exceptional circumstances. But actually, it's nation states and communities that have ongoing responsibility for what happens in the world. Ideally, we want to be equipping them to also be very good at responding to emergencies without external exceptional help. And I wonder how we can think about the kind of long-term process of kind of doing ourselves out of a job and kind of transitioning and embedding responsibility for emergency response in countries, and the nexus of how we can build stronger systems for response being something that's automatically, routinely done well by countries without the need for external agencies coming in, either UN ones or international NGO ones.
During the past 2 days, we have heard that there is a problem of funding for thematic groups and others. So I think, do we need a strategy to actually look at how do we develop a funding strategy, and that we together come either it could be thematic strategy or interagency strategy. I think this is the main role of the next co-chairs, that also the members that we also have to contribute. I think there is a need for funding strategy development.
I agree. I think that's such an important conversation to have. I think as an agency that has co-chaired a working group, and also we are co-chairing multiple actually, and we are participating in some, we know that funding for the work plans of the working groups comes from multiple sources, and it's not always funded through the funds that come to the actual work plan, because there's a lot that's developed through the TOR process. So I agree. I think there's a good opportunity to rethink that strategy moving forward, and what is working and what isn't. Yeah.
Exactly, and how can we pool funds? Usually we'll see one agency step up when they're able to do internal advocacy. How can we learn from those internal advocacy efforts and try them out in our own organizations to see how we can get more organizational commitment to support these very important thematic groups, and to show that link, how it has that trickle-down effect in reaching all of these countries that we're supporting anyway. How can we position ourselves better? So I think that's a lovely recommendation. Thank you.
Maybe just to build on that slightly, I think also exploring a funding strategy that covers things outside of the squarely humanitarian sector, because I know for our thematic group, that's a big problem, and it's excluded, I think, by a lot of donors who are interested only in humanitarian activities. But I imagine that other thematic groups like livelihoods and others may also have similar challenges with getting some of the things funded. So I think funding across the nexus would also be helpful.
Thank you for the input. Definitely things to consider while moving forward.
Thinking about some of the conversations we've had over the last 2 days, just thinking about the question of inclusion and the future of this group. And I think, we have a 2-year extension of the mandate, but the world is changing, the IASC is changing, humanitarian work is changing. We need to think about how we're going to position this group for success in the future, but also to embody the values that we are increasingly articulating in terms of who gets to participate and on what terms. And I think that's something that we could use the next period to be kind of creative and thoughtful about. And also perhaps think about where are the big pushes that we want to make in terms of, I guess, technical and governance and, you know, more kind of programmatic kind of impact on the field. And maybe that's something we might not come up with by tomorrow, but it may be something that we actually put on the agenda to take us into the future.
Thank you, Ananda. And I think if you remember yesterday, one of our colleagues, while presenting, asked, is it that we follow the money or we follow the lead, the need? So it's just one of those things that we should really be thinking about.
Yeah, within our thematic group, peace building in MHPSS, we're also discussing now a bit more the HDP nexus. And I think this would be a request, at least from this group, to look a bit further how to link the coordination mechanisms that are existing between the humanitarian actors with the other actors, and also with regard to further sustainability. When we talk about sustainable structures in the countries we're working, I think we have to extend this picture a bit more.
Thank you for that.
Yeah, no, I think also the reference group, I think, has evolved, honestly, over the last few years. I think with the evolving landscape, I think now we have, for example, the working group on DRR that includes, you know, actors that working on climate. So I think there is precedence for us kind of expanding the way that we look at emergencies and the scope of our work. Yeah, and I'd be excited to have that conversation. Yeah.
This is indeed the future of the group, you know, because I think, you know, there is as much as we can do in formalizing the humanitarian intervention, you know, so that's it, you know, so and I think actually we are even overproducing, you know, tools, you know, in the last period just to justify the technical working groups, you know, existence and so on. So I think obviously, you know, we should expand, you know, and go towards other directions. However, the guidelines were created really for humanitarian purposes, you know? So trying to force that document into these new other fields, as we are doing, you know, in many situations, is not necessarily useful. No? And so, if we want really to expand, there should be a new, no, vision, you know, on how we really engage with peace building. That is not only the pyramid, you know, but it's much more than that. You know, there is a political dimension, you know, that is somehow less present in the humanitarian field. If we want really to work on development, you know, what does it mean, you know, in a changing environment, climate crisis, you know, right. So these are the things that I think, you know, are important to look at, but we cannot do it from a comfort space. Saying, okay, we have the guidelines, you know, the guidelines are great. Now we try to, not to tell to peace building actors, use the guidelines. They're not enough. And they are not done for that, actually. They risk to be very reductive, you know, in that sense. So that's my... Would you have recommendations? So basically, you know, if we try to expand the field, it means that we have also to reach out to new actors and include them, you know, and also to create new space for discussion and probably dedicated, you know, tools that are not just, you know, breakdown of the main one.
Absolutely, and I would support having these spaces, creating these spaces. I think, you know, something that's exciting for me every time I come to these meetings is, you know, there's still so much we're learning about the work and the priorities of each other's organizations, the tools. You know, I just learned about, you know, ACF and some protocols for EMDR and CPT. I'm like, wow, I had no idea. I'd love to chat with you. I think creating these spaces based on the priorities that you're all identifying and seeing how we can better facilitate that, that's the whole point, right, is really fostering this information sharing and helping advance priorities, each organization's priorities and our collective priorities. Peter, I'll get to
you. Just one thing that I think should be said, although I'm not sure what my position is, but the guidelines are 17 years old. Should we not have a discussion? Either we're going to renew it, we've said it last year, but this meeting not yet, or do we say this was it? But I do get the questions in my organization when they're updating guidance. They say, there is still a very old guidance here. I assume that's not valid anymore. And I say, no, it is. Keep it in, keep it in. So either we say we did our job, we have a lot of other tools, so we could say we don't need more. We have the MSP, we have lots of other things, or are we going to revise the document? And my God, that will be a process. Or maybe not, because we can refer to existing tools, which we could not. But in general, every revision of an IASC interagency product leads to a bigger document that is not necessarily more useful, but we need to think about this. And maybe that's something for the next co-chairs to guide us through.
It's too complicated, Peter.
I know, we're all avoiding it, but that's why I put it here.
I think about it all the time, honestly.
Oh, really?
But with no solution, because we're, like you said, we're developing so much through our working groups. So there's so much already on MHPSS and peace building and MHPSS and DRR. And a lot of it builds on the principles of the guidelines. And this idea of reviewing the guidelines is very intimidating, honestly. And I know there were attempts in the past. And to this day, honestly, even when I'm talking to somebody like a generalist, everybody loves the pyramid still, right? Like it's like the core of any conversation that we have with a non-MHPSS person.
But we refer to the guidelines where there is no GBV chapter. How can that be? So there is an outdated thing.
Yeah. No, it's true. It has its faults, for sure. Yeah.
I would politely ask the three contending agencies, and I'm very careful about the terminology here, not the three coming co-chairs, the three contending agencies for tomorrow election to wrap up in 2 minutes, because everyone needs to go in a bus for the site visit, and others would need to start the the steering group meeting. So please, let's try in 2-3 minutes, because buses will leave immediately at 5.
I would say let's use the 2 minutes for any more feedback from colleagues. Any direction that you have, maybe ahead of the elections, what would you like to see? What are you thinking in terms of agencies that will represent you and represent the reference group? Marcia,
one thing that I would, looking ahead as well, is improving perhaps what I would call information management systems, in a way that there is so much going on. Even myself, I get lost. Even us that are used with toolkits and more or less organizing it, that has been enormous, a lot, and sometimes overwhelming. So that would be an interesting thing that is also very much linked, not in curating research, but information management is also means that how do we make information really available, which links to transparency process. No? What are the transparency mechanisms that we could, in a way, make it transparency, not because there is something hidden, but something that that could be more visible to everyone, be aware of, and linking with, and building from.
Thank you, Marcia.
But maybe, Peter, the idea of redoing the guidelines makes me slightly ill, but I think that what Marcio just said is really important, because maybe that's the revision of the guidelines. You know, we've produced an amazing amount of documents. The guidelines are kind of a summary of what we've just produced. So part of what I'm thinking is maybe it's not as hard as we all think, is that when in fact what we would do is write a consolidated document, and it would take and use what Marcio just suggested, which is it's a consolidated way of understanding all the tools that we've produced. And it would summarize all of those and give it new meaning. Right? The pyramid would continue to be there because, in fact, the pyramid is very much the way of summarizing what we do. So it might not be as hard as we think it is, since we have all these tools as well. So I would very much want the new people, whoever they are, to be thinking about that. I don't, as hard as it is, I do think it's necessary. And I think it's not, maybe it's not as hard as we think it is. It's not like it was last time. Last time we were building on nothing. I mean, remember, those who were writing last time, we were building on nothing. Now we have so much to work with. So I think it's quite different than it was before. Yeah.
Thank you so much, Nancy. You just made things sound very light. I believe in the process now. I'm converted. This is, thank you so much, Fahmi, for the opportunity to give us the floor to speak to colleagues. I've been told there's a bus that people need to run to and a picture that we also need to take. So really just thank you for sharing with us, and to be continued really would be my message. And thank you again for the opportunity to be nominated for such a position.
UNICEF, IMC, IFRC, good luck, colleagues. If we can vote for the three of you, we should. The three of you are nice, but this is not about nice colleagues. This is about agencies. Let's all remember that. With this, we end the annual meeting of the IASC reference group. Let's all together have a group photo and quickly run to the buses.